want to welcome you to the 2020 State of Aging Conference. Again, my name is Diane Martin, and I am the Director of the Geriatrics and Gerontology Education and Research Program at the University of Maryland, Baltimore, where I'm also an Associate Professor in the Graduate School. At this time, I want to take a moment to thank our supporters for making this program possible. Number one, we have support from the Johns Hopkins Geriatric Workforce Enhancement Program, the Maryland Living Well Center of Excellence, Home Instead Senior Care, and Mutual of Omaha Mortgage. Thank you to those supporters for helping to make this conference, bring this conference to you. And thank all of you for attending as well. We really appreciate that. I see that we have about 100 people logged in right now. We have close to 150 people registered for the conference, so I'm sure we'll be having more people join us as the morning continues. I know that this year's conference looks and feels different, but I am also confident that we will capture the same energy as we've done in previous years. COVID-19 has affected all of us. It's caused us to work, learn, and live differently, but no group has been impacted more than older adults. Our conference booklet that you should have received as part of your registration packet, it was located in the email link that you received. There's a conference booklet in there, and also we'll get it loaded into the chat box so that you could download it from there if you haven't already downloaded it. But the conference booklet illustrates just how much older adults have been impacted by the COVID-19. In fact, according to the CDC, 8 out of 10 US COVID-related deaths have been people 65 and older. So over the next 3.5 hours, you'll learn more about efforts across the state to reach older adults who may have been isolated as a result of COVID. You'll learn about efforts in the medical community toward vaccine development and strategies that you can use to meet the needs of our older adult population. I am pleased to once again be part of this annual conference, now in its 5th year, and to bring it to you in partnership with McDaniel College and the Central Maryland Area Health Education Center, both of whom you'll hear from next. Thank you.
Good morning. I'm Roger Casey, the president here at McDaniel College. And on behalf of McDaniel College, our Board of Trustees, our Master of Science in Gerontology, and our Center for the Study of Aging, I want to welcome all of you to the very first virtual State of Aging conference. Prior to COVID, McDaniel hosted this annual conference on our campus for several years. While I'm disappointed that you will not be visiting our beautiful campus today, McDaniel is excited to partner with the University of Maryland Geriatrics and Gerontology Education and Research Program and the Central Maryland AHEC to bring this conference to you virtually. COVID has certainly presented many challenges for McDaniel over the past 6 months, but like others, we're embracing technology to continue our educational mission. This semester, we're delivering many of our undergraduate courses using a hybrid or an online format, and our graduate programs are being delivered entirely online. So Zoom and Teams meetings, virtual recruiting, virtual trainings, and professional development, these are all now a part of our daily routine. It's an interesting time, certainly, and I believe this conference is a good example of how technology has allowed us to pivot to continue to deliver exciting quality educational experiences. McDaniel is also proud to be a part of this conference because now more than ever, professionals who are serving our nation's aging population need to come together to learn and share information about how to keep our seniors healthy and safe during the pandemic. It's important to me personally because I'm an only child who has 2 aging parents in their 80s, so I understand this problem very personally. Equally important and equally as challenging during this time is your role in addressing the social and emotional needs of our seniors. The focus on COVID-19 for this year's conference, it's not only needed, it's essential so that we can assure we're able to meet the shifting needs of older adults during and following this pandemic. So I thank you I thank you for the important work you do each day, and I thank you for making time to attend this event. And I also would like to thank our speakers, Secretary Kramer, Dr. Chen, Mr. Brown. We are very honored to have you as part of this day. So I hope you all have a great conference. And once again, welcome to McDaniel, U.S. News and World Report's #1 best value college in the North.
Thank you, President Casey. Good morning. Thank you for joining us for the annual State of Aging Conference. This is the first in a series of webinars that will be offered this year by the Maryland Area Health Education Centers, addressing topics related to caring for others and for ourselves in this uncertain and demanding environment. It is our hope that this conference and our future conferences will support you in the work that you do by providing you with additional tools for professional development and resilience. I give a special thanks to our conference partners, University of Maryland and McDaniel College, and to our supporters. I also extend my sincerest gratitude to our presenters, Secretary Rona Kramer and Dr. Wilbur Chen and Mr. David Brown. In addition to serving as the Executive Director of Central Maryland AHAC, I'm honored to serve Governor Larry Hogan, Secretary Kramer, and the citizens of Maryland as a commissioner on the Maryland Commission on Aging. So today it is a special privilege for me to introduce the Honorable Secretary Rona Kramer, Esquire. In 2015, Governor Hogan appointed Rona Kramer to serve as Secretary of the Maryland Department on Aging. Prior to being appointed to this state cabinet level position, Secretary Kramer worked in commercial real estate development and management. Secretary Kramer was elected to the Maryland Senate in 2002, representing District 14 in Montgomery County through 2010. While a member of the state Senate, she was a lead sponsor for bills establishing the Silver Alert Program and protections for seniors from financial exploitation. As the Secretary on Aging, she leads the Department on Aging's efforts to protect the rights and quality of life of our elder residents, and most importantly, to provide the services necessary to allow seniors to age at home. This morning, I am honored to present to you the Honorable Secretary Rona Kramer.
Thank you, Paula, very much. I have to tell you all that I have very much looked forward to being here again with you. I spoke at this conference when I first began my gig as Secretary of the Department of Aging, back when I was young and innocent. Of course, after experiencing 2020, I'll never be either of those things again. There are really only two words that can properly describe aging in 2020. Oy vey. It's been a very interesting, very difficult year. For those of us in aging, very challenging, but for the people whom we serve, this has been a year of everything from extreme inconvenience to heartbreak, very much loneliness, and pure terror. These are the people, this is the cohort whose friends and spouses were dying in the highest numbers, and as you've already heard this morning, continue to. These are people who cannot see their children and their grandchildren, some of them now for 7 months. These are the people who've experienced the most isolation. in especially those living in assisted living, nursing homes, and even those living in independent living at continuing care retirement communities. It has been extremely isolating. And you add to that that this is the cohort that is least adept at using technology, that has kept the rest of us afloat throughout this pandemic. But it is the generation also, many of whom who survived the Great Depression, a world war, Vietnam, and even the Jimmy Carter administration. So we know that they can handle challenges, and I am extremely impressed by the way that they are. So what have we been doing at the Department of Aging? From the very beginning in March, the state closed senior centers, and that created an immediate need for home delivered meals. Now, our area agencies on aging have always provided home delivered meals, but we had a sudden spike, both from seniors who were taking part in the congregate meals in at senior centers, but also those who now could no longer get out to the grocery store. And that was a huge percentage of them who didn't have someone to come and bring groceries to their home. And so we had a sudden spike in our home delivered meals program. And if I could see slide, thank you. So this slide is showing you the number of meals that we're providing now. This has only been the number that we've served for the last 2 weeks. The minute that COVID began and we closed the senior centers, our home delivered meals deliveries increased by 500% overnight. And they remained at that level from about 40,000 a week to 180,000 meals per week. And it continued until 2 weeks ago at 500%. It has now in the last 2 weeks dropped to about 300% increase in home delivered meals. That was a tremendous job that our area agencies on aging have done, not only to find the meals, and they've had to procure a tremendous amount of food, but also then to find means to deliver those. And so our area agencies on aging have done spectacular work in addition to everything else that they do. Slide 3, please. Our senior centers had to go virtual. And you couldn't go virtual without first teaching so many of the participants how to participate in virtual programming. So our senior centers have accomplished that. They're giving classes and providing assistance to people who need it to be able to use our virtual senior centers. And they are the programming on everything from museum tours to group bingo, social events, knitting and sewing classes, and very importantly, fitness and meditation classes. So they've done a tremendous job of stepping up and providing these services. And many, many of our local jurisdiction area agencies on aging are sharing their programming statewide to give a very broad group of programs available to everyone. So they've really done spectacularly there. Slide 4 shows that information about Caregiver Services Corps. You don't need to read all of this, and we can probably make these slides available if you'd like. But we were concerned at the start of the pandemic about having a surge that would overwhelm our hospitals, as we saw in Italy and in New York City. And so Governor Hogan wanted to be sure that Maryland never experienced a surge that would prevent anyone who needed proper care in a hospital from getting it. And so it became the responsibility of the Department of Aging to find a method to serve our older adults who were very dependent on a family or home caregiver that was not a paid caregiver. And we know we have hundreds of thousands of older adults in Maryland who are dependent on neighbors and friends and family who come in to the home to them and provide the most basic services, help them get out of bed, assist them with toileting, with fixing a meal, and as well as moving around their home. What would happen to one of those people if their caregiver became exposed to COVID? So we were very concerned that their only option would be to call 911 and end up in a hospital where we did not want them to go. So we established very, very quickly the Caregiver Services Corps. And we now have and have been operating a call center where anyone who calls 911 or 211, this slide is, we've jumped ahead one. Anyone who calls 911 or 211 can be connected with our call center. We then connect that individual with someone in the Maryland Medical Reserve Corps who has proper medical training to meet the needs of that particular older adult, and we then serve them on an emergency basis until we can assist them to find longer-term solution for their care needs. Okay, now senior call check. The Department of Aging already had a program in place called Senior Call Check. It is a daily check-in call, free for any Marylander 65 or older, and we call every day just to be sure that the individual can pick up the phone and is not languishing on the floor after having a bone break or a heart attack or a stroke and cannot get to their phone. And this program, we had been operating already for a number of months before COVID. When COVID hit, our numbers increased dramatically, and we're consistently serving about 1,100 call recipients a day. In addition to that call, during COVID, we have added a weekly live call just to check in. Our callers are trained to recognize elder abuse, which is a concern, as well as depression, maybe needs for food and food insecurity. And so we can assist in many different ways when we do our check-in. And we've got some really devoted recipients who are very enthusiastic about the program. It has run very smoothly, and we're very pleased to be able to have provided it. Next slide. Needless to say, the Ombudsman program has been overwhelmed with calls. The Ombudsman is the advocate in the state of Maryland for residents of nursing homes and assisted living facilities. And so they have not been able to go into those facilities, so they are providing their services by phone as well as virtually, and they have performed some amazing service. And I can tell you that I had a contact from a woman a couple of months ago whose mother was in a nursing home, and she told me that her mother stops eating. Her mother suffered from dementia, and that her mother would stop eating when she did not go in to visit her mother when she couldn't be there. And so the nursing home called her and told her that the mother had stopped eating and was really not doing well. And she called and said, "We can't get into the nursing home. I can't go in to see her. What do we do?" And this was early enough during the pandemic that we didn't have some of the compassionate care rules established. The nursing home made arrangements. It was a lovely day. They brought the mom outside. The daughter spent the day with her mom, and her mom passed away right there with her at the end of that day that they spent together. And I got a call back from the daughter who said that her mother had passed away peacefully, and that it was the most important thing that could have possibly been done for her mom in their lives. And so the ombudsman made all of the arrangements to make that happen. The ombudsman is extremely important to us, and I have been mightily impressed by all of the work that they've been doing. Next slide now brings up what the Department of Aging is doing for the future of aging. 2020 has been tough. We will continue to work extremely hard to bring all the services that we possibly can to older adults in Maryland. And these programs now are the future of aging. And we do know that that's around the corner, and very much looking forward to continuing to make aging in Maryland much better. So first program I'd like to tell you about is the Maryland's Communities for Life. This program began about 4 years ago. It is the first in the nation of its type. And here's what we realized needed to be changed, and we absolutely believe must be changed if the trajectory of aging is going to improve. Right now, the current trajectory for aging is that you're independent, you live on your own, you have to take care of yourself until you spend down and become indigent, at which point government steps in and provides programs for you. There are a few exceptions to that, but very few. So it seemed to us at the Department of Aging that we needed to change that. We needed to prevent the spend down and allow people to continue to take care of themselves, but with some assistance. So here's the kinds of assistance that we knew was necessary to prevent the need for moving into higher levels of care. This is just a slide to show you where we're currently providing Community for Life. We hope that in the next year or so, we will be available throughout the state, but we have just about half the seniors in the state of Maryland now covered by a Community for Life should they decide to join. So Community for Life is a membership program. It is provided in conjunction with the state of Maryland and non-profit providers who have a great depth of experience in supporting older adults in Maryland. The program is one where we create a membership organization. Most of these now are county-wide or jurisdiction-wide, and the provider, the nonprofit, becomes the Community for Life in that jurisdiction. And we provide the basic services necessary to keep people living independently at home for years, maybe even decades longer than they currently can. So we provide home maintenance. There is a handy person in each community, at least one, who's available on a phone call to come over and change a light bulb in the ceiling, or maybe cut a branch down from a tree. And that will prevent our residents from a fall, from climbing on a ladder. And we really believe that we will keep people safer. I'm only going to be able to go through very briefly the program and what it provides, but the services are extremely deep. And to support people, we prevent fraud by having each provider has a list of vetted contractors for the big services, like a roof replacement or repair, or something that's bigger than the handy person can handle, so that we prevent fraud, which is a tremendous problem for our older adults. In addition to the maintenance service, we provide service navigation. Each community has at least one service navigator who stays in touch with the older adult, gets to know them, knows what family they have in the area, the kinds of things that they like to do, and checks in to make sure everything is okay. They are always available to the member, so they know all of the services that might be available in the community, so our older adults can take better advantage of all the programs that we have. They also will recognize isolation. So if the service navigator calls Mrs. Jones one day for her regular call, check-in, and determines that Mrs. Jones is not getting out now, a few months after Mr. Jones passed away, the service navigator can say, you know, Mrs. Jones, I know that you've been telling me for years now that you love to read, and there is a new book club that's just started in your community, and they would love to have you join them. How about if I make arrangements and we make sure to get you to the next book club meeting? Then the final service that we provide is transportation. And that may be transportation for anything at all, a social event, doctor's appointments, whatever it is that's important to that individual. These services are all provided at a price, a cost in the membership fee that is far reduced from anything that they could possibly procure on their own, even if they had the ability to procure all of those services. So next slide shows you just a quick comparison between nursing home, assisted living, and the cost of community for life. And we have heard from some aging experts that they consider this to be the holy grail of aging. And we believe that people will be staying out of nursing homes, avoiding higher levels of care for years to come. And we hope that they'll be able to pass away with their assets intact to pass on to their children and their grandchildren as an additional benefit to this program. The biggest problem that we have found in this program is marketing it, because you can't describe it in a soundbite. It's nothing that they've ever seen before. And we've all learned that when something is too good to be true, it must be too good to be true. And in this case, it is too good to be true, but it is actually true. It's a fantastic program at fantastic pricing, and we have wonderful nonprofits partnering with us, and will be and are currently gathering data. We will be working with CRISP and actually proving that this program will keep people living at home independently far longer than they could possibly otherwise. This is when President Casey mentioned in his opening remarks that he's an only child with parents, two parents to care for. This is the kind of program that makes aging so much easier for the entire program. I have one more program I'm just going to mention very briefly. Next slide. The state of Maryland is the first state in the nation to open its own state-operated durable medical equipment reuse program. And the state of Maryland now is open. We have a warehouse. It's been open for about a month and a half now. We are currently taking donations of all types of medical equipment, everything from walkers and rollators to motorized wheelchairs and hospital beds. And we then sanitize the equipment to national protocols, and we repair everything that goes back out, and we will be providing this free of charge to the public. We will serve the entire population, and we'll have a pediatric section as well. So if you're interested, if you know of donations you have available, please, I think the next slide has our information. You can see this is the equipment that we have brought in just 1 month of being open, some very sophisticated wheelchairs. And we will have the warehouse in Prince George's County in Cheltenham, Maryland, where we will be distributing and taking donations, but also we will have drop-off and pickup sites throughout the state. So thank you very much. I very much appreciate being here, and hope you all enjoy the entire conference. Thank you.
Thank you, Secretary Kramer. We do have a couple of questions in the chat box, so I'll go ahead and read those to you, and then you can respond. The first one is, someone is wondering whether the Community for Life program is similar to the Village programs, or in what ways might they be different? And as a second part to that, since Village models also have a fee involved, how does the CFL program fees relate to the Village fees?
Thank you. That's a great question, and it has been asked many times. The difference is that right now there are far more Maryland residents who do not live in a community that has a village than those who do. This program, if we are to tackle this issue quickly, we determined, and that means change that trajectory of having a fall, being defrauded, therefore having to move into higher levels of care on Medicaid. If we were going to change that trajectory quickly, we had to do something quickly. And this Community for Life program provides these services very consistently with all of the services mentioned: maintenance, service navigation, and transportation, consistently to every member throughout the entire jurisdiction. So that's one difference. The villages are terrific, and villages can work with their Community for Life. One does not mean that the other shouldn't exist. Our village volunteers are spectacular, and so they can continue to provide lots of programming that they do. They can provide additional social and community activities. So it is not one or the other. Community for Life, though, we have been able to expand to provide the service to more people more quickly, more rapidly. As to the pricing, they differ in every village. and our communities for life differ depending on some additional services that some provide. The average is $185 a month for Community for Life. Thank you.
And then I have, it looks like 2 more questions, and they both relate to the durable medical equipment. So I'll combine them. The first part is whether you are working with the area Lions clubs on the medical equipment. And secondly, for this program, is the equipment delivered to the individual, or must they have the ability to pick it up?
Good questions. We have been in touch with the Lions since the start. I happen to be a member of my Lions Club and have been for decades. And so, yes, we certainly are working with them. We're letting them know that we have equipment available so that when they have someone comes into one of their community programs and asks for something that they don't have available, we can make it available. And then we have professional repair accessible to us. So if they have something that they would like to have repaired, they can bring it to us and we'll help them with the repair, which many of them can't do. So yes, this has been a team effort, and we want all programs that are currently existing for durable medical equipment to work with us. That was, and the ability to come in, most people will need to come to one of the sites, not up to the warehouse, but they'll need to come to one of the sites so that we can verify that the equipment that we're giving to them is the right size and provides the proper service to them that they need. We can't just hand equipment out without training people on it.
Thank you. Thank you very much. It looks like that is all the questions and thoughts. I appreciate your time. Thank you, Secretary Kramer. Your information was valuable, especially given where we are today. I have been in touch with your office about the durable medical equipment, and I know that that is a much needed service in our state, so thank you. It's also really interesting to see how Maryland is working to meet the needs of older adults and the programs that are available and the expanding programs that are available throughout the state under your leadership. So thank you for that. I encourage all of our attendees to visit the Department of Aging's website for more information on the programs that Secretary Kramer presented, and to contact their county area or their county agency on aging with other specific questions as well. So thank you, Secretary Kramer. And I'm gonna clap for you because I can, but I'm sure everybody else is very much appreciative of your information as well. That's the weird thing about these webinars. We just don't get that feedback, that the imagery that we do, but thank you. I really appreciate your time this morning.
Thank you. The pleasure has been mine.
All right. Okay, so our next presenter is Dr. Wilbur Chen. And Dr. Chen is the Chief of Adult Clinical Studies, Center for Vaccine Development at the University of Maryland Medical Center. He is an adult infectious disease scientist with a specific interest in clinical vaccinology. Welcome, Dr. Chen.
Hi, good morning. Hopefully you can see me. Should I be driving my slides, or will you be driving them? I'm prepared.
I don't have control of the slides, so I think you need to be in control of them.
Okay.
Is that all right with you?
Give me a moment. Host disabled participant screen sharing. So I guess I just need privileges.
Oh, okay, yep, someone just emailed me. Angela says you need to control your slides. So Angela, does Dr. Chen have the privilege to do that?
Hold on, I'm fixing it.
Okay. Well, while we're trying to fix it, good morning, everyone. And it's really just a privilege for me to be able to speak to all of you this morning. When I was doing my internal medicine training, did a lot of geriatrics. And so I've always had a specific interest in the aging adult population. With respect to my profession now, which is vaccine development, a lot of the vaccines I really have a mind for trying to develop vaccines that are optimized for the older adult population. So we'll talk very generally about COVID today. Let's see if I can get the up. Yep, let's see. So let me go ahead and do this. Share. And hopefully you can see my slides now. So I work at the Center for Vaccine Development and Global Health here at the University of Maryland School of Medicine. And so let's see, I think I've been given this, the topic of trying to describe to you in just 60 minutes, and actually I think hopefully I'll limit it to just 50 minutes so that we can have proper time for a question and answer, to talk about COVID-19, to give you an update, and the three major areas that I'll talk about today are transmission, some of the therapies that have been developed or that are kind of our ongoing knowledge, and the vaccine development efforts. Okay, so I do want to disclose that I do have some potential conflicts of interest, but again, these are predominantly funded by the federal government. You can see that I've been a co-investigator in some of the trials that are ongoing. I'm funded also by the CDC to do kind of a surveillance, and also even working very closely with the Maryland Department of Health in standing up the serosurveillance that is going on, which is among hospital EDs and also among firefighters and other subpopulations that we're very interested in. So the outline today is I'm going to give you a very brief overview of just my idea of emerging infections, and COVID-19 just represents one of them because we continue to be under this threat globally at any single time. I'll talk about COVID-19, some very basic principles that I think that we should walk away from today. And then I'll talk about the transmission therapies and vaccines. So first of all, just an overview of emerging infections. This is just, 25 years of recent history in which I'm just mapping out for you many of the emerging infection pathogens that we've been tracking, and some of them may be known to you, some of them may not be known to you. Perhaps more recently, you'll see that in Central Africa and even in West Africa, we had Ebola breakout at 2 different times. We continue to see Ebola actually in Central Africa, in the Congo. To this day, we've heard about dengue. Dengue started out in kind of the Pacific Island areas and in Southeast Asia, but now has encroached into the Americas. So it continues to be something that we see even introduced occasionally into like the Florida Keys. And then now we're seeing COVID-19. So again, we continue to see these emerging infections. And why is this? Well, because a lot of these pathogens actually reside normally in the wildlife around us. And so they may or may not actually even cause disease among the wildlife around us. So if we talk about influenza, which I've been studying for many years, but there's decades of experience, is that we know that it normally occurs in birds. Many of these birds are migratory birds, shorebirds and waterfowl, which again, you can look at the flyways of these migratory birds. So if you see these birds, they have flyways that are well described that again, circumnavigate the globe, going from northern hemisphere to southern hemisphere. Again, going to find better pastures for the different seasons of the year, for the different times of the globe. And so again, with these birds that migrate very long distances, they carry these viruses very long distances, and they will end up in the backyard of someone's farm. So in all of these locales, you'll see that we have domesticated birds such as turkey and chicken. We also have domesticated animals. All of these are potential introductions of these viruses among these birds into our domesticated animals. And of course, we humans, farmers, can also be secondarily infected as well. So again, that's what always happens is that for coronavirus, for influenza, and a lot of these others, is that these viruses exist in these populations, these animal populations. So we call these zoonotic infections. And so for influenza, we have WHO surveillance network of centers that are always tracking these influenza viruses. But you can imagine that this would be a global effort on many fronts for different types of pathogens. So for coronaviruses, we've actually had some human coronaviruses for many years. They're known as common cold agents, so we don't kind of distinguish common cold viruses. It could be adenovirus, rhinovirus, coronaviruses, and many other types of viruses. But they also represent zoonotic threats because, again, they are endemic globally among bats. Bat populations all throughout the world have coronaviruses that they carry. And again, they can fly around and infect intermediate hosts or infect the human. And that's how we have these outbreaks. And in fact, we've had in recent human history, the SARS coronavirus breakout in 2002, the Middle East respiratory syndrome coronavirus, or MERS, in 2012, which exists still to this day in Saudi Arabia. And of course, SARS-CoV-2, which is what we call COVID-19, is the disease that it causes. And you're looking at, again, the case fatality ratios that are known among these viruses. Again, these broke out and had limited transmission with SARS and MERS, but SARS-CoV-2, of course, has global reach. So COVID-19, moving to the present day, we're learning a whole hell of a lot, and just realized that we've only known about this virus for about 7 months now, and our understanding continues to evolve. But this is what we presently believe about the virus and are important features that we need to understand. So there's a period of infectiousness that could be as early as 2 days from the time of exposure. And it could be that you could be infectious even 15 days out from that exposure or from that time of testing positive. Now, on top of that, there are a large portion of people that may be asymptomatic or pre-symptomatic. So that means that a person may be exposed, may then be infectious, but may not be symptomatic. And again, those are the difficulties that we didn't understand early on, but now we're understanding more and more, which make it very difficult, which means that, again, that contact tracing is such an important element of us to be able to contain this virus. But also it means that for our older adult population, especially those that are in assisted living or in any other skilled nursing sort of setting, it becomes difficult because, again, there may be infectious transmission of people, and we just don't know because they're not symptomatic yet, or they may not become symptomatic at all. And of course, we know that the burden of disease, severe disease, which is hospitalization or risk of death, is highest among older adults. And so you're seeing this graph here that I grabbed from the CDC, an infographic. But again, it really shows you how with increasing age alone, that there is this risk of hospitalization. So let's talk about transmission now. So the basic, if you don't learn anything else from today, is that it could be either two modes. It could be from exhaled breath, which is how it goes efficiently from person to person, or environmental contamination, the fomites, or other things, which is why hand hygiene and cleaning of high-touch surfaces is so important. Now, I'm not going to talk much about the environmental contamination because, again, that's the same for all of these other viruses, or even C. difficile, or some of these other pathogens where, again, we want to continue to practice environmental cleaning of surfaces because of the risk of contamination and spread to others. But let's talk about this person-to-person risk and exhaled breath. Well, the story becomes more and more complicated because traditionally we talk about respiratory droplets versus airborne. And that becomes a problem because even for the CDC, because that is a textbook definition in which we define droplets by a criteria saying that it's either less than 5 microns or more than 5 microns. And that's really not the story. And this is a decades-old kind of definition that we're using. So it's really not just respiratory droplets. we are learning more and more that these infectious particles can be and are less than 5 microns, which means that they can stay suspended in the air longer. These exhaled breath particles, they can be carried in air currents, which means small air currents indoors, or even air currents outdoors. So if you're standing in a line going into the grocery store and the air is blowing down that line and you're behind people and they're not wearing a mask, you'll get infected because you'll be splashed right in the face with those infectious particles. And that happens. Even in outdoor dining, you can have, even if you're spaced apart, you can have air currents that are carrying those infectious particles. Indoors, again, we have more stagnant air. We don't have air moving around as much. And of course, we don't have UV decontamination traditionally. So again, that's why indoors can be worse than outdoors. And of course, ventilation is a key part of us understanding the infectiousness of this. Now, you're seeing these two infographics, one infographic, I should say, one from the CDC, Are You the Office Sprinkler? Again, this is just reminding you to wear a mask when you're out and about. Universal masking really should be our stance. The bottom picture is my colleague, Don Milton, who's a colleague at College Park, who's a physician, occupational medicine physician who is spending his career studying exhaled breath and airborne particles and those sorts of things. And he developed this apparatus to be able to measure the size of these particles. So again, we are learning more and more about COVID-19, but again, the bottom line is these infectious particles can be much smaller. Well, here are some studies to give you an idea of how infectious it is. Well, in South Korea, there are call centers. Here's a high-rise building in which the 11th floor, you can see the schematics where there are a number of, what do you call them, teleworkers, people who are monitoring the phones and answering them. And so all of the blue highlighted areas are confirmed cases in this single outbreak. And so you can see a number of them were symptomatic, but then you can see a number of them were pre-symptomatic or asymptomatic. And also you can see that there were a number of secondary infections as well that were documented. I'm showing you this because I'm showing you that indoors transmission can be highly efficient, especially if you have an outbreak situation that is unrecognized. These people are sitting close to each other, they weren't masked, and again, you can see how efficiently this infection moved through this particular floor. How about restaurants? Well, this is an indoor restaurant in China in which you can see that there was air conditioner, which was blowing air in this one direction. And there was this index patient that happened to be infected. He was eating with his family here. There was another family at tables B and C. And again, you can see that 9 cases were documented from this one outbreak. These dates are basically the dates of onset of illness from this particular outbreak. Family B basically had overlapping time for their luncheon of 53 minutes. So that's the time of opportunity for the transmission of the infection. Family C, which is really in the opposite direction of the wind blowing, you can see, had overlapping time between their luncheons of 73 minutes. Well, to give you a better idea of why the air blowing and why the family C did get this infection is because when they did modeling of the entire airflow of this, there was actually other airflow. These air conditioning units actually were not being used, but there was a counter current. And when they modeled, you could see that there was an eddy where the flow of air was actually, there was an eddy in the back of this room of this restaurant where, again, you can see why those other individuals were infected. So again, giving you an idea of the infectiousness of the particles. Many of you have probably heard about the choir outbreak. So there was 2.5 hours of choir practice. Again, exhaled breath, where again, the energy produced by singing. 61 people attended this March 10th choir practice and 53 people, 86.7%, were infected. 3 hospitalized and 2 died. Again, showing you the importance of the exhaled breath. A fitness class in South Korea. Now, this was described as basically set to Latin rhythms. So this was a very exuberant class, it sounded like. These were across 12 different sporting facilities conducted by 27 instructors. 8 of these instructors were infected and went to these 12 different facilities and conducted these classes, and 112 cases resulted from it. So again, giving you an idea of exhaled breath under those circumstances when you're, again, performing aerobic activity. What about flights? Well, first class is not completely safe. There was a 10-hour flight from London to Hanoi, and there were 16 crew and 200 passengers aboard this flight, and 15 became infected. That's 8.7%. Now, what you can see is the orange, the red is the index patient, and the orange were the additional cases that resulted. 12 of the 15 were the business class passengers. 2 of them were in economy. 1 person was a flight attendant. I guess they schematically put that person here, but probably circulated through the cabin. So what's interesting is that 11 of the 12 business class people were just 1 to 2 seats away from the index patient. Again, giving you an idea of the infectiousness of the particles from an infectious patient. And lastly, of course, because we have an eye toward older adults, is a nursing home. This was a documented nursing home with inadequate ventilation for one of the wings. There were 7 wards that were described. One of the wards had this energy efficient system in which automatically it would kind of turn on and off, and basically it would monitor indoor carbon dioxide concentrations, and when it became elevated, then it would switch on. Well, again, when you have air that's not circulating at all times, that becomes a risk. And so again, in the other wards where they had the older, less efficient systems, which basically were on all the time, basically, and not, saving energy, but were on all the time and circulating air efficiently, none of the people were infected. But these energy efficient systems, which again, in another year, probably are a very good idea. But again, the idea is proper ventilation would probably be a long ways toward preventing these infections. So again, what I want you to take away from this is that there are a number of mitigation and control measures that we can use to limit transmissions within our facilities. So I'm giving you this upside down triangle to say, for example, the most efficient thing is to do telework, teleeducation like I'm doing now, telehealth, where again, we're limiting any contact at all. When we have to be present, we want to do physical distancing as much as possible. And I'm saying 6 feet may not be enough. That is the absolute minimum that you want to maintain. But if at all possible, 20 feet, 50 feet would be great. Okay, now, of course, in our profession, that is not possible. So, but that's the philosophy that we have to adopt. Administrative changes may mean that, again, shift work, so that you're alternating shifts, so that you have less density in a particular room or a particular facility. You're also implementing physical barriers like the plexiglass barriers and those sorts of things. You're maybe implementing better ventilation measures. And of course, again, when we have to be face-to-face with an individual, again, physical therapy, occupational therapy, feeding, all of these other measures where we have to be present right there with the participant, with the person that we're working with, PPE, proper PPE. So again, all of these things we have to keep in mind to limit transmission. All right, so therapeutics and vaccines, I know that that's probably something that you're very key on understanding. So therapeutics, our idea is we're trying to learn much more and every day about the life cycle of this virus in specific. And one of the things that we do know is the general life cycle of coronaviruses. And so we know that the receptor requires this ACE2, it requires fusion, it goes into the host genome and has to be replicated so we can perhaps take and hijack some of these features for antivirals that are being developed. Again, most of the time it takes years, decades to develop these antivirals. So again, we don't have that amount of time, but so a lot of what we're doing is trying to take things that are ready off the shelf. But we're trying to hit multiple parts of the virus life cycle to be able to diminish this virus. And so again, you're seeing that some of the things that we're talking about is monoclonal antibodies that can perhaps affect the viral entry. And one of the major aspects of the virus in terms of us trying to use is the spike protein, which is this kind of lollipop-shaped thing on the surface of the virus that you're seeing. And so it's important, again, for entry and for exit of the virus. You're seeing that there are other host-developed therapies. Again, because of the virus, when it infects the host, we see that there are a number of other immune responses that are very much altered, that could be deleterious to the host. And so we're trying to see if some of altering those responses, such as the inflammatory response with IL-6 inhibitors, which are traditionally used for rheumatologic diseases, interferons, those sorts of things, maybe using and repurposing traditional medications that we use for diabetes or cholesterol treatment. Again, some of these things might actually have features that would alter the host response for the inflammatory response, or other parts of the response might actually help out with the severity of disease with infection. Not that it would prevent infection, but it would actually alter the severity of the infection. So again, there are a number of therapeutics. And so when I last looked, and this was just last week, September 22nd, there were 575 therapeutic products that were listed in development. And so different phases of development. Some are under emergency use authorization or compassionate use or expanded access, but some of them are in phase 1, 2, or 3, or 4 testing. Some are preclinical, some are discovery. Some of the ones that you're seeing, again, are things that are already licensed and just being repurposed to study to see if we can actually use it as a therapeutic modality that might actually work. So, you know, we have a lot of unknowns that are in development. And of course, along the way, we have to understand, is there any efficacy? Is there really any use out of a lot of these therapeutics that are being used, either repurposed ones or the ones that are being developed? At the same time, we want to know if there is actually harm, you know. So a lot of the things that we are studying that are being repurposed may actually introduce harm. So, you know, for example, hydroxychloroquine or chloroquine, you know, the anti-malarial. You know, we understand that there is some cardiac toxicity. So again, we've looked at the efficacy. It looks like there really is not much efficacy, or the efficacy is just so small that you have to treat large numbers to get a pretty small effect size. And at the same time, the harm, you know, again, the balance between efficacy and harm, you know, the harm may outweigh the true efficacy. So again, these are evolving concepts or things that we understand as we go through all of the therapeutics. So glucocorticoids, you know, we've had a major study called the recovery study that was done in the UK by the MRC, the Medical Research Council, which is like the NIH for the UK. Performed a very large randomized clinical trial and demonstrated 17% overall relative reduction. That's overall, but if you look specifically at the patients that were on mechanical ventilation or ECMO, you had a larger effect size of 36% relative reduction in mortality. This is 28-day mortality. So again, you know, that's rather significant. Again, I would, you know, if I had patients that were very ill in the hospital and I could save them 36% relative reduction is significant enough that I would try this modality. So again, our thinking now is that we use dexamethasone, 6 milligrams once a day for 10 days, or if they get better until discharge, so whatever is shorter. If they are discharged earlier, great, terrific. If we don't have dexamethasone, you can substitute it for hydrocortisone or methylprednisolone or prednisone at those doses as well. It looks like the data right now suggests that there's really not much benefit for patients that really have mild disease, that don't require ventilatory support or oxygen. So again, it's for our hospitalized patients and those patients that require mechanical ventilation. Then there was also the remdesivir trial. So, and again, for disclosure, I was one of the co-investigators for this trial, but this was a large trial that was conducted by the NIH. And so if you looked at the publications, and there are several now, there was 31% faster time to recovery, so 11 days versus 15 days. And there was that survival benefit of 8% versus 11.6%. And again, if you did a stratified analysis, the benefit was actually much more profound among severely ill patients, those who required mechanical ventilation and ECMO. But there was still benefit for the more moderately infected. So remdesivir should be given at 200 milligrams on day 1, once daily, for the next 5 days at 100 milligrams. And for patients that are severely ill on mechanical ventilation or on ECMO, they can receive remdesivir for a total of 10 days instead of just 5 additional days. So that's our current understanding of remdesivir. Convalescent sera or plasma or immunoglobulins, the jury is still out. So, there are some small scale studies and other studies that either show some slight benefit or no benefit according to some meta-analyses that were recently performed. So again, efficacy data I think are still kind of pending for us to be convinced, and studies are still ongoing. However, there is centuries of data on just kind of anti-sera for a number of different pathogens in which it has been highly efficacious. So anti-tetanus, before we even invented vaccines, anti-sera were effective means to prevent mortality with a lot of very severe and important infections. So we have a large amount of safety data. So I'm showing you a medRxiv preprint in which this graph is showing you at least 5,000 patients that have been transfused so far with convalescent plasma or sera. And really the safety has demonstrated that it's not unsafe or that it's really a question of harm. It's really a question of whether or not we can have efficacy proven from these modalities. So that's really the state of it. Unfortunately, we don't have much more in terms of therapeutics to offer at this time. We have a number of repurposed therapies that are being looked at. These are all, again, FDA-approved drugs for other purposes. So HIV antivirals are being looked at, hydroxychloroquine, as I mentioned, azithromycin, colchicine, losartan, other statins, other kind of oral diabetic agents. All of these are being looked at under randomized clinical trials. We're also looking to see if we can block many inflammatory mechanisms. So that might mean inhibition of IL-6 or GM-CSF or some other receptor antagonists that are in the inflammatory pathway. Antivirals. Remdesivir happened to be an antiviral that was being studied for influenza and Ebola And there are other antivirals that have been developed and were being studied for other pathogens like Ebola or influenza, and are again being looked at this time for whether or not they might work for COVID-19. Interferons are also being studied. In fact, right now, Act 3 is looking at that. Tyrosine kinase inhibitors, these are basically anti-cancer agents that are being looked at as well. Again, looking at the inflammatory pathway or other pathways. Synthetic human angiotensin 2, again, looking at the ACE kind of pathway as a way to basically treat recombinant C1 esterase inhibitors. There are a lot of things that are being looked at. I think the bottom line is, if you're thinking about supportive care and what to do for a severely ill patient, is of course our tried and true, that supportive care, mechanical ventilation and ECMO are important modalities. And in fact, I think that there was a publication just yesterday that I saw that was really talking about the importance of ECMO and how a significant number of patients are being rescued with ECMO therapy. All right, so let's talk about vaccines with the remaining time that I have. And so, you know, there are a number of technologies that have been used, and this is my space that I live in. So, in which I have been trying to develop a number of vaccines for a number of different pathogens using all different types of what we call platform approaches. And what we really mean is that, you know, for a bacteria or a virus, we know that there's a certain part of that bacteria or virus that we need to show to the immune system to have an immune response to be protective. In this case, for coronavirus, it's that spike protein, which again is that lollipop feature that you see as a part of the surface of the virus that, again, we think is the most important part for a vaccine to express. And so for influenza, it's the hemagglutinin, which again is a virus that has these particles on the surface of the virus. But we could be talking about bacteria like tetanus toxoid or other things. Again, that's part of the vaccine. So the traditional approach is that we have to use some way of making the vaccine, the protein or whatever it is. And so, for example, for influenza, you know, for many decades, we've used chicken's eggs. And what we do is, on a huge, massive commercial scale, millions of eggs are being produced every year by these certified commercial poultry farms that are keeping their hens under pathogen-free conditions as much as possible, just for the manufacture of our influenza vaccines every year. And what it does is we load them up on a conveyor belt and they go through, and there's a machine that injects a little bit of the virus into the egg. It goes into an incubator for a few days, and that virus continues to replicate in that chicken egg to more and more numbers of virus. This is how we make more numbers of the virus itself. Then it goes through the conveyor belt a little further, gets cracked open into these huge commercial sized centrifuges, and you have these, you know, the chicken yolk and the whites and whatever are centrifuged until you get centrifuge out the viral particles. Then it goes through a number of what do you call it, sieves and other kind of approaches to purify out just the virus itself. Then it goes through an inactivation phase, blah, blah, blah. You can think about this as a traditional approach that we do every year to make flu vaccine, and that's how we make our vaccines. What I'm trying to describe to you is that this is a massive approach, and this is not the way to make a vaccine for a global pandemic in a short period of time. So what we've come up with is trying to make vaccines with newer approaches and what I've called future approaches, which is because these are not FDA approved as of yet. Although right now, these are the ones that are the fastest. So, okay, let's talk about these newer approaches. There's live attenuated viruses. So the Oxford AstraZeneca is a live attenuated chimpanzee adenovirus vaccine. So you take a virus that's well known, that's attenuated, which means that it's a weakened form, or it's a form of virus that does not replicate at all in the human host, but it still can produce the proteins that you pop in. So genomically, you've engineered in the spike protein of the coronavirus into this chimpanzee adenovirus, and it basically expresses the spike protein. So when you inject it into a person, it's not going to replicate, but it's going to make the spike protein enough that you get an immune response to the spike protein. And that's how you make the vaccine. Cell culture. Well, that's a way where you get away from chicken eggs, but you still have the right growth conditions where you have a vat, like you think about beer or wine, where you have the right growth conditions where you put in the virus and you have the right cells there to replicate the virus. And then at the end of the day, you can purify the virus out and purify the spike protein out. You can have recombinant, which is, again, some of the companies such as Sanofi Pasteur is making a recombinant, and I think Novavax is also making a recombinant protein, spike protein based approach of making that spike protein. And basically what you're doing is genomically engineering some cell of some type to crank out large amounts. And so again, this is how we make large amounts of hepatitis B virus vaccines, which is a recombinant based vaccine, and you make large amounts of the protein. So for hepatitis B, it's a hepatitis B surface antigen, and for corona, it's the spike protein. You make large amounts of it, highly purified amounts, and you can make that as the vaccine. And you can combine it with these adjuvants, POW, which basically stimulate the immune response to get a better vaccine response. So you combine these recombinant vaccines with adjuvants and you get a great vaccine. So those are approaches that are already FDA approved approaches for other vaccines. Now, future approaches are the ones that we don't see that are licensed vaccines, but again, mRNA or DNA-based vaccines. So these are like the Moderna vaccine or the Pfizer vaccine that are being developed right now. Virus-like particles, virosomes, virus vectored. Again, virus vectored actually is basically the live attenuated, where you take again a different virus and engineer in the specific part, like the spike protein, into that virus. The live attenuated actually is more like, traditionally the approach is like the measles vaccine, where it's an attenuated measles virus that you're injecting in that doesn't cause disease, but it is a measles virus. So again, the virus vectored is a different virus that you pop in the particular, say, protein of interest, okay? So those are all the different approaches for platform approaches. Let's talk about these these vaccines in specific. So again, when I looked at the world of vaccines that are under development all throughout the globe, as of last week, it was 177 that are under various phases of development. Now, the ones that we're hearing the most news about are, say, the Moderna vaccine, which is, it's this mRNA 1273. It's an mRNA-based vaccine. It started clinical trials here in the US on March 16th. We also had a company called Inovio with CEPI support, which is an international kind of nonprofit foundation that's kind of trying to generate this. This is a DNA-based vaccine. It started clinical trials in April. The Oxford the Oxford vaccine, which is AstraZeneca's vaccine, this is that chimpanzee adenovirus vectored vaccine. It's a viral vectored vaccine, as I said, started clinical trials in the UK in April. The Pfizer vaccine, another mRNA-based vaccine. This is the BioNTech or BNT162 vaccine. Started clinical trials in Germany in April, started clinical trials May 5th. And so again, for full disclosure, the Center for Vaccine Development, where I work right now, is one of the phase 1 clinical trial sites for the US. So again, was the major site for the first in-human studies of the Pfizer vaccine. Novavax is this nanoparticle. You can think of it basically like a recombinant based vaccine that is combined with an adjuvant. That started clinical trials in May. There's a Janssen or Johnson & Johnson owns this sub-company called Janssen, which is a vaccines company. It's a virus vectored, it's an adenovirus 26 based vaccine. And so that started clinical trials in July. And Sanofi Pasteur, another recombinant spike based protein combined with an adjuvant. And that started September 3rd. So again, these are the ones that you may hear most about. A lot of them are part of this Operation Warp Speed. What I'll describe to you is what is the known data right now that we have for publications. Well, the phase 1 study was published in the New England Journal already for the Moderna study. It was a so-called preliminary report. What you're seeing, and maybe the font is too big, but at least what you can see is here on the left-hand side is describing, if you can't see this, but it's saying, what the symptoms were. So it's any symptom or arthralgia, fatigue, fever, chills, headache, myalgia, nausea, any local symptom, the size of erythema or redness, the size of the induration or swelling at the injection site, the amount of pain. And then you're seeing here graphing the different dosages. So this is 25 micrograms, 100 versus 250 dosage of the Moderna vaccine. So according to each of these symptoms. And again, these histograms are showing you the percentage of the participants that described any of these symptoms like arthralgia, fatigue, fever, after the first vaccination and the second vaccination. And what you can generally see is that the second vaccination has more reactions than the first. Overall, the reactions were mild or moderate. Mild is the gray, moderate is the blue bars, severe is this yellow bar. And what's not published in this, of course, table is because they can only visualize so much data, but it's definitely in the text of the article, is that these were short-lived. So they were about 1, 2, or a maximum of 3 days. But again, it's giving you an idea in a nutshell, looking at this, about the reactogenicity of the vaccine. So there is some pain, injection site pain, and swelling and redness. But again, it's predominantly mild or moderate. Again, I would not think that this would be preventing us from wanting to vaccinate individuals. Again, if you were to vaccinate people with influenza vaccine and use the same instrument for reporting of the reactions, I think that you would see something very similar to that and tetanus vaccine and any of the other vaccines that we use these days. So I didn't see anything alarming in the data. Here are the immune responses. And so what you can see are the immune responses against the spike protein. This S2P is it's a spike protein that has these two prolines that have been genomically engineered so that it's the pre-fusion form of the spike protein, which is the form that we want, by the way, to not have these so-called bad reactions. Or the receptor binding protein, which is a specific part of the spike protein, or by this pseudovirus, or by this virus neutralizing titer. And again, all of these are different antibody assays. And what you're again seeing is that according to 25 micrograms, 100 microgram dose, or a 250 microgram dose, and over different days. So again, this is the first dose and then the second dose, first dose and second dose. You can see that there is an antibody response that's documented with all the different types of antibody assays that are being used. And yes, that second dose does result in a boostable dose. So the two doses really do look like they're necessary, not just a single dose, in order to get the best responses. Now, the Moderna study right now is going forward with the 100 microgram dosage, because according to these data, you can see that you don't get much more antibody response for the 250 versus the 100 micrograms, but the 100 did look like in many instances you got a better response compared to the 25. So that's how they landed on the 100 microgram dose to go forward with the phase 3 studies that are going on right now. All right, the AstraZeneca is the other one that is being that has been published. And again, this is the reactogenicity displayed, of course, in a different way because it's different, set of investigators. But again, I'll try to navigate you. So this is induration, itchiness, pain, redness, swelling, tenderness, warmth over the injection site for the first dose, and then the second dose of the vaccine. This is chills, fatigue, fever, feverishness, headache, joint pain, malaise, muscle aches, nausea after the first dose or the second dose. And again, yellow is mild responses. What is this? Salmon pink is a moderate response. If you saw red, it would be severe. And then hyper intense red would be hospitalizations, of which they didn't see any documented. And again, you can see that in general, first dose was associated with more reactions than the second dose in this. But again, they were mostly mild, maybe some moderate. Again, I didn't see anything here as far as the safety of the vaccine where it was performing any differently than say a flu vaccine or a tetanus vaccine or another licensed vaccine. Okay, so here are the immune responses. So one of the controls was to give a meningitis vaccination, and so what you're seeing is the ELISA antibody responses, again, are being looked at after the first dose, the prime or the prime boost, which is basically a booster dose. I think it was given 6 months later. And so you're seeing that there is a boostable response. So people who got the control vaccine basically predominantly had no response. People who did get vaccination, you saw that the vaccine response started rising at around day 14, but they basically peaked at day 28 after vaccination. After the second dose of vaccine, it remained elevated here. And then there's a booster dose where, again, after that vaccination, there is a boostable response. Convalescent, so people who got natural infection, these are their responses comparatively. So again, their claim is that their vaccine results in responses that are equivalent to people who got natural infection. All right. So that's kind of the world of global vaccine development. In the US, we have Operation Warp Speed, which it has a goal of trying to have 300 million doses of an effective or a set of effective COVID-19 vaccines by January of 2021. It's headed by a number of people that are, shepherding this effort. But on the global stage, there are a number of things that are going on. So there's something called the ACT Accelerator, the Access to COVID-19 Tools. And this is, again, where the rest of the world is going. So there are billions of dollars in global pledges. Really, the goal is equitability, to try to make all of these vaccines, therapeutics, diagnostics available at affordable prices, and also available to developing country settings where, again, where we are seeing the burden of disease hitting less developed countries, which really don't have the economic kind of engines to be able to support what we're able to support here in the US. And so again, that's where we're seeing a lot of this. So it's a coalition of countries, big pharma and nonprofits. And so again, this is the effort that again, the rest of the world is trying to stage, where we're seeing a large part of the burden of disease, where we know that it's affecting specific vulnerable populations. So as far as vaccine policy and implementation, so, just getting a vaccine tested and available is only part of the equation. So at first, even if we have vaccines licensed, we should understand that there will be limited doses that will be available. So we have to try to figure out how are we going to allocate these limited supplies. So prioritization of high-risk populations, trying to figure out how can we maximize the utility of these vaccines in the face of a limited supply. And how do we also do it in an equitable way under an ethical framework where we've talked about this under a stance that we can back up with ethics and morale. We are developing national guidelines to try to balance, a national level approach, but also allowing for flexibility at the local jurisdictional level. So, North Dakota is not the same as New York City. So again, rural areas are not the same as every urban area. Access and delivery, how are we going to get all these vaccines out there? The different storage conditions, the different ways of use. How are we going to continue to message this out? Right now, according to a lot of polls, less than 30% of people would actually give vaccine to themselves or their families if a vaccine were available. That's terrible. That's just terrible. So we have to work on messaging. So, we need to maximize the benefits, minimize the approach, have an equitable way that has justice and fairness built into it, transparency, it has to be evidence-based, has to be feasible as well. All of these things are part of the implementation of the policy. Population risk groups, again, healthcare personnel, among which we are probably about 20 million across the US. Essential workers that are non-healthcare workers, the estimate is about 60 million. Older adults comprise about 53 million across the US. People who have high-risk medical conditions for COVID are probably a little bit greater than 100 million. And our total US population is 330 million. So how do we equitably allocate these limited resources, which again, might only be 10 million at first for the first month, and then 20 million for the second month, and then 30 million for the third month, and so on. So again, how do we slowly but surely get these vaccines out there to the people who really need it? And so you can see a Venn diagram. So again, healthcare personnel can have high-risk medical conditions. We are essential workers, and you may be among those adults 65 years of age and older. So again, you might be in that sweet spot, which is not so sweet looking to you for COVID, for a high risk of COVID. So again, how do we equitably get these vaccines out there? So the conclusions, again, I'm going to be just brief, is there are a lot of therapeutics that are being evaluated and a lot of vaccines that are underway. Glucocorticoids and remdesivir are the ones that have been proven. We think that chloroquine should not be used because there's really not efficacy. The Moderna and Pfizer vaccines are under phase 3. There are a number of vaccines that are also about to go underway under phase 3. The AstraZeneca is on hold right now. Stay tuned for whether or not that'll come off of hold, but it is off of hold in the UK and continues to be studied. And this is my last slide. Again, vaccines and therapeutics development. Really, the underlying principle is that it usually takes decades for us to go from discovery, preclinical, all the way through developing a vaccine, having it licensed, having it delivered, and showing impact and using it in a population. And this is according to a public health need and or a market need and public will. And so under the circumstances of a pandemic, of course, there's the public health need. The market need we've largely eliminated because of a lot of investments across the board by nationalities, by nonprofits, by pharma, making big investments, basically saying we're going to go ahead and plow forward with making vaccines, even despite we don't know if it's going to be efficacious. So they're already doing that. And of course, political will at multiple different fronts has to push this all forward. But this is part of vaccine development in a pandemic and outside of a pandemic, but it just depends on how big or long this timeline is. So thank you so much for allowing me to talk today. This is the end of my talk, and I'll allow for the rest of the time for question and answer.
Well, thank you so much, Dr. Chen. We really appreciate your information, and I think your presentation just really provided us with so much more information that helps to clarify what we hear in the news every day. So I am really appreciative of the information, which I'm sure all of our attendees are as well. We did get a number of questions in, so I'm going to start with this first one. Someone is asking whether it's okay to encourage long-term care communities to participate in the COVID prevention network trials, like the one that's looking at the prevalence in older adults. And if so, what is the best way to educate concerning participation?
Yep. So the bottom line is, yes, I would encourage participants, either healthcare workers or those who do reside in these facilities, to look at a number of these trials, to look at the eligibility. Some of them may be variable, and some of them, these participants may be excluded if they are, but a lot of them are inclusive. And in fact, I would say that a lot of them are looking for enrolling people in populations that are at risk, no matter what they do. So again, just by virtue of your occupation, which you can't control, you have to go to work, you have to be under the environment where, again, you might be exposed to patients with COVID-19, or you could be talking about a person who works at the grocery store, again, and is exposed to COVID-19 by virtue of their occupation, and they have to do this. Their lifestyle dictates that they may be under risk. And so participating in the trial will help us because, again, they would be the ones that, again, would allow us to understand whether or not the vaccine is efficacious. Now, of course, there's a 50-50 chance whether or not they get vaccine or the placebo. And one of the questions is, if I'm in a study, one of these vaccines becomes licensed and approved, am I going to be able to get vaccinated? And the answer is yes. Whether you're in one of these studies or not, when these licensed vaccines become available, we will assuredly allow you to get vaccinated. So again, it doesn't preclude you from being able to get vaccinated. Again, we're looking at people who are at high risk. And again, that could include people who are in skilled nursing homes or other facilities, that will potentially be, under risk of an outbreak. Again, we know that across the US, we've documented a number of nursing home outbreaks.
Thank you. So two related questions. Number one, I know that Maryland at one time was recruiting older adults, specifically for your phase 3 randomized trial for testing. Are you still recruiting? And if so, could we share the flyers so that older adults who are unrepresented in research, especially when we're thinking about vaccines, and they are a high risk as well as minority populations. So if you could just talk just a minute about recruitment of older adults and minorities and how we can help spread the word.
Yeah, so we actually, for the Moderna trial, I think just closed out that part of the recruitment because we've had a pretty good showing of older adults. We continue to be recruiting, but actually we're very close to ending recruitment. But that's not the end of the story because there are a number of other candidate vaccines through the COVID Prevention Network. So other vaccine studies will be opening soon, for which, again, older adults can be involved. So again, stay tuned. The door is not completely closed. It's just this particular vaccine candidate and this study. But again, I'm not really vested and interested in one particular candidate. I would love for all of these vaccines to be successful. At the end of the day, if we have a handful of vaccines that are licensed and approved, great. So again, just look forward to seeing if any of these studies become available. We do have a website here at the CVD for which if people are interested, they can look at the website. They can enter their information and then we'll contact them. So it's really an internet-based where they can enter their information, their age, just selected demographic features, not HIPAA information that allow us to get that information, callback information, and then we'll contact you again when those studies open up.
Thank you. And we'll get your website information into the chat box for people who are interested.
Awesome.
The next question is, do you expect that a successful vaccine would have to be taken annually, much like the flu vaccines are done now?
Yeah, that's a great question. And I don't know the answer to that yet. A lot of people have been talking about that after this season or after we're done with this pandemic, however long it occurs, that this virus will not just disappear, just like other coronaviruses don't disappear, or influenza doesn't disappear. It becomes a seasonal virus. But hopefully what will happen is that once we've had the so-called herd immunity and the global population predominantly has had exposure to the virus, that or immunity from vaccination, that it'll become one of the seasonal common cold viruses. And you know, again, it will not be this heightened public health threat that we are experiencing right now. But again, it may not be so important to be able to get annual vaccination, just like we're not vaccinating against seasonal common cold agents. Or it might be that for the first couple of years, maybe you do have to get a booster dose prior to that season. So that's really not determined yet, but that's a very good question. That could be for a few years, but the hope is that it would become just a seasonal common cold virus.
Thank you. All right, just a few more questions. First, is live attenuated vaccine riskier and therefore requiring lengthier or more involved trials, and possibly limit who this type of vaccine might be approved for?
So, you know, it's unproven because we don't have an FDA approved kind of vaccine that kind of paves the path forward for us to really understand, you know, the so-called harm. But so far, under all the studies that have been done, the viral vectored vaccines, which have been studied for Ebola and other pathogens, again, they haven't been licensed and approved, so not widely tested as much as, you know, influenza virus vaccine. You know, we just don't have the amount of safety information with the number of people that have been actually, you know, immunized so that we can track the so-called safety. But so far, we have not seen a safety signal. However, you know, again, the Oxford vaccine did have that one halt. We saw the case of the transverse myelitis, which is still under approval by our US FDA. And again, may give pause. So again, I really don't know the definitive answer, and that's why I think I would continue to just be evidence-based and look for any evolving data about this. So that would not, you know, preclude the Moderna or the Pfizer studies, which are the mRNA-based vaccines, again, which are not licensed vaccines. We don't have other licensed vaccines which are mRNA-based, but again, we have not seen safety issues with those vaccines so far.
Okay, so that kind of relates to the next question as to whether or not scientists are sharing data, and not just here in the United States, but really across the world. Are they sharing with other countries to reach a solution more quickly, or does it still appear that money is the big driver? Asks.
Yeah, well, the good news is that, you know, largely all throughout the world, data is very much being shared. And in fact, I've been pleasantly surprised by the rapidity of publications. Peer-reviewed publications have been coming out daily or weekly, very, very quickly. Traditionally, it would be a press release, you know, by the company that you would see shortly after, you know, trial results were unblinded, and then it would take many months or maybe a year or two to see the proper publication. Right now, you're seeing press releases, and then within days, or sometimes the same day, that the actual publication will come out. You know, so really, you're seeing very little time delay. You're seeing a lot of transparency. However, you know, again, for Russia and for China, you're seeing that they have their own kind of internal national vaccines that they are developing, that they've already so-called licensed or approved and are using in their own respective countries nationally for their pandemic responses. We don't have a lot of data on those vaccines, but they're not intending to use those globally. So it doesn't become a problem with the global vaccines that are being, again, staged for use all across the world. So for the rest of those vaccines that I mentioned, at least, those vaccines that are meant to be used globally throughout the world in multiple different countries, largely we're not seeing a problem with the sharing of data, which is great news, which means that, again, the scientific community has largely been very enthusiastic about sharing as rapidly as possible.
Thank you. And it looks like there's just one more question. I've heard that a vaccine can sometimes increase a person's autoimmune response and start a cytokine storm. Do you know anything about research regarding that issue?
Yeah, there are some vaccines that have adjuvants in them that are intended to stimulate the immune response. And so these adjuvants are tuned, again, so that hopefully they're not over exuberant in their response. But again, like the shingles vaccine, which is highly successful, Shingrix has such an adjuvant in it. And a lot of the people that have described to me that have received the vaccine, and many of you who are listening right now have received the vaccine or given the vaccine, know that oftentimes it's after that second dose that you have a more profound immune response or the pain and fever response. And oftentimes it is after that first dose even. So that is probably explained by most scientists believe that it's because of the adjuvant. That is the adjuvant that is being, the same sort of philosophy or scientific basis is what is being used for the adjuvants in the COVID-19 vaccines that are being developed. So it's not intended to be over exuberant as like getting infected with, COVID-19 itself, where again, a lot of the response may be because of an immune response that has gone awry. It is, again, intended to give a better immune response so that you get a better vaccine response. And again, it's short-lived. So within a day or two, the pain and swelling and fever go away. Again, with Shingrix, it gives you an idea of how prolonged that immune response and how profound it can be. Again, some people have described to me that it took 3, 4, 5 days, but it was pretty painful and they didn't feel like doing anything for the first at least day or two after vaccination. Again, would I rather get COVID-19 vaccination or a sore arm and not feeling like I'm at my best and really just kind of want to stay home and minimize my activity for a day or two? I'd rather have that vaccine rather than get COVID-19 infection. So again, that's the trade-off.
And it looks like there is one more question, but I think we've answered it, at least partly.
Okay.
The person says, most studies don't include older adults or adults over 65 and people in smaller demographic groups. Are they included in the studies to ensure it will work in all populations?
Yes, and absolutely, that the phase 3 studies that are being done right now or being planned to be staged very soon all have the idea of trying to make sure that the inclusion of the general population at large is a part of the population being studied, and that we're studying specific parts of the population that are under high risk, which includes older adults, and also some of the racial demographics that we know have had high burden of disease, which is the Latinx community and Black community, people who have certain comorbid conditions like cardiovascular conditions, liver disease, kidney disease, diabetes. So again, those are all inclusive of the studies that are being staged and planned. So the answer is yes.
Thank you. Did just get another question, but I am going to also let people know that we'll take a 10-minute break so that we can stay on track. Dr. Chen is also going to be speaking. We have 2 more conferences scheduled, one during the winter, the Western Maryland Area Health Education Center, AHEC West, will be hosting Dr. Chen. It's scheduled. I think it's going to be this winter, so look for emails related to that. And then the Eastern Shore Area Health Education Center is also hosting Dr. Chen later this spring. So our goal is really to have 3 consecutive events where we hopefully learn more about the disease each time. So Dr. Chen, I really appreciate your time this morning to help us really make sense of what we hear and reduce, I think, some of the fears that people have about the vaccine and the disease in general. So thank you for that. So
it's my pleasure, and I'll look forward to those future times when I talk, and I'll be able to update those slides as well.
Thank you. And so we are going to take a 10-minute break, but Dr. Chen, if you can hang on just a few minutes if people want to unmute themselves and ask you questions, and I'll get this question started. Dave wrote, do you see any spin-off benefits from these studies on other diseases? So you can answer that. Everyone, you can take yourself off mute and show your image if you'd like, and network and ask Dr. Chen some questions. And as a group, we'll reconvene at about 10:50. Thank you.
Yeah, research in general builds upon research. So what we learn from this pathogen, we learn and try to adopt to other pathogens as well. So I think, again, we will take all of these lessons learned, even as we learn about, particle size, as I said, exhaled breath. We will take these lessons learned about pandemic responses and try to apply them to future pandemics as well. So I think, again, as we go through this experience, hopefully we'll not forget and we'll carry these all as lessons forward. Not a lot of people are sharing their video. I want to see faces.
Here's Secretary Kramer's back, and I saw Kathy Shalega, Delegate Shalega, had also joined us earlier, so I'm really appreciative to have some of our representatives here as well. Thank you.
I think a lot of people are probably taking a bio break. It's about that time, so.
Yeah, that's what I'm thinking. So
yeah,
I so much appreciate this, and you and Secretary Kramer spending time. So we'll just take a break, and if there's no more questions, I don't see any other questions coming in.
I just want to say thank you, Dr. Chen. You did an awesome job. I'm Dorcas Baker. I asked that question about the COVID Prevention Network. So thank you. Really enjoyed you. Thorough, very thorough. Thank you.
You're welcome.
The same way, and I'm purple background for going purple in this, this month for opioid, stigma, etc. Thank you, Dr. Chen.
I'd like to say thank you to Dr. Chen as well. I have pages and pages of notes here from your comments, and I'll pull up your slides as well. So thank you very much. Very informative.
Sure.
With the purple background is Western Maryland AHEC, so they are the next group to host you, Dr. Chen.
Right. Terrific.
Well, good afternoon, everyone. Let's get started with the second half of today's conference. First, I'd like to thank you very much to our presenters this morning, Secretary Kramer and Dr. Chen. And thank you very much for your questions and your engagement in this morning's presentations. I'd like to remind you that if you are obtaining CEUs for your attendance today, please send Meredith Hockman and note in the chat privately so that we can be sure that we've captured all of your contact information necessary to help you achieve your CEUs. At this moment, I'd like to introduce Mr. David Brown. David was born in Baltimore City, and he attended Coppin State College, Coppin State University, and received a degree in special education. His degree has spanned more than 20 years and has included teaching, education, and juvenile justice administration and program development in children's mental health. In 2015, Mr. Brown left response-driven treatment to fund ECHO Resource Development Organization, which is a multi-service 501c3 nonprofit that connects people and organizations that serve them. ECHO's trauma-informed human systems approach strengthens the protective factors that are the foundation of healthy social networks and human systems. ECHO has provided consultation, professional development, education, and resource development services to schools, communities, businesses, and organizations throughout Maryland and neighboring states. Mr. Brown is a behavioral health trainer extraordinaire and is one of the Danya Institute's preferred trainers and is a colleague and one of our premier trainers with the Central Maryland Health Education Center. And I turn it over now to Mr. David Brown.
Well, good morning, everyone. It's a pleasure to be here. I know listening to that introduction, it seemed like why am I here when we're talking about seniors and aging? But the real focus is about a human systems approach, an ecological approach. And as we look at trauma, resilience, and aging during COVID-19, we're not looking at individuals. We're looking at individuals as a part of communities, whether it's a city, a county, a retirement community, a family system. And that's really what the focus of this brief presentation will be. Strongly encourage you to go ahead and ask questions throughout this presentation if you'd like, but we're just going to go ahead and get started with our ground rules. If we can. So first of all, life is a participation sport. Come to play. And we need to know that emotional safety is more important than physical safety. And that's not just for us as we're talking about, but as we think about seniors, as they're aging, about anybody where we're introducing the concept of change, that often we will put ourselves in physical harm or take greater risks in order to maintain emotional safety. And then we need to respect differences and the need for differences. The other is that it's okay to be human, particularly during this time. What we found that people are struggling because we don't have in-person human contact. And so while we're on Zoom, things happen. And when it first started, we thought it was funny and people were trying to hide what was going on. But we actually build an alliance when we see our humanity. And by that, I mean, if we see kids in the background, pets, or hear noises, it lets us know that we're not alone in this. And that speaks to the ecological approach of creating health and safety. And of course, spelling does not count. That's mainly because of me, because I'm a horrible speller, even after all the years I taught and ran schools. Our goals, really broad. This is usually a full day, if not multi-day, sort of event when we talk about trauma, resilience, and building safe, healthy, and supportive communities. But we want to identify the ways in which people can become traumatized. Well, we're going to define trauma, identify ways in which people can become traumatized, review the Adverse Childhood Experiences Study, better known as ACEs, identify the impact of trauma, and then identify the ways in which we can build resilience. Perspective. This is really important, not only for us as professionals, but when we think about the seniors as they get older. My mother, who lives 5 doors up from me, is 88. She'll be 89 soon. And we get into these arguments about what she knows and what I know and how the world has changed. But the older we get, we believe we have seen it all. But what we've actually come to find out is the more we see, the more blind we become, believing that we've seen it all, and then we lose the sight of what could be. So we get stuck in this, well, I've seen this before, and we judge people 9 out of 10 times, or all people alike, and this is part of that stigma that comes along with being a part of any group, but certainly in aging. So norms versus expectations. We had intended to use a poll, but technology got in the way. What's really important as we think about what we want to do in terms of creating change, helping people, whether through trauma, toxic stress, through aging, or anything they're going through, is understanding the difference between norms and expectations. So the poll we wanted to use, and I'm going to ask you guys to answer the question in the chat room by, here, let me pull it up, giving you 3 options. So when I ask the question, if you believe your answer to be true to it, you're going to put a 1. If you believe your answer to be false, put it as 0. Okay. So the question is, do you believe yourself to be a law-abiding citizen, generally following the rules? Just go ahead and type in, if you believe yes, you are, put 1. So we equate norms and expectations as the law. Right? But norms are more powerful than the law. And here is an example. The speed limit on I-95, the posted speed limit is 65. However, as a law-abiding citizen, regardless of profession, you better not be going the speed limit in the left lane. Okay? So really think about this. You better not be going the speed limit in the right lane most of the time. So we all consider ourselves rule followers. We have all these rules and we don't understand why people don't follow them. Or, we put these rules in place or these expectations in place in order to maintain a balance, a sense of safety. But norms are more powerful than expectations. And we'll talk about why that's important. Age supports health and wellness. Just in case where we dropped out, I believe, is what we're talking about, the power of community. Okay. And the power of community is far greater than any physician or clinic or hospital. And what we mean by that, it takes a community to sustain the work of physicians, of clinics, or hospitals. We can also move into prevention by creating communities of health. And that's where we get into our work around human systems, which is based on an ecological approach, which takes the inherent qualities, whether they're physical, emotional, mental, and how they interact with a person's environment. And this, if you haven't heard, is called an echogram, but this is a senior-centric one. So really think about, because there's hopefully going to be the opportunity to do some breakouts to get the input about what are all the influencing factors on the health and wellness of a senior. Are we still cutting in and out, or does it sound better? I see it in the chat room. We'll keep trying. So again, think about the human connectedness. Human connectedness, we cannot create an individual who is healthy without looking at the system. Okay. And I'm gonna come back to this, this video, ironically from home instead, because I want you to hear Mary's hilarious prayer where she actually talks about some of the things, some of the perceptual issues, the things around resilience. Oh, we're gonna, all right. The other concept, particularly around trauma and resilience, is that behavior is a form of communication. It is not the problem, it is symptomatic. So as you think about how we're supporting seniors now through COVID-19, but prior to COVID-19 and in the future, we often react and perceive who they are and what they need through their behavior. But the concept you have to have is to really think about behavior equating with the pain of cancer. And if you were only to treat the pain of cancer to give it Tylenol, morphine, or any painkiller, and not treat the underlying cancer as a disease, that cancer is likely to metastasize, spread, and we'd lose that patient. So when we look at this ecological approach to understanding trauma and its impact on seniors, we have to also look at ourselves and the networks around us. It is not just about how we can best support the seniors, but how do we create an environment that promotes health, wellness, and safety for all of us. And here are some of the behaviors that we tend to respond to with seniors. Okay. So relationship problems, particularly and this could happen across the lifespan. So you'll see this. Social alienation. So these are things that we see across the lifespan, but we believe, that we start seeing perhaps for different reasons, underlying reasons, as people get older. And then there's self-doubt, self-blame. Again, really think about these. These don't have seniors or older adults in here. These are things that can happen across a lifespan. But because many of us work with older population, or we are older, we begin to attribute these to people who are older. And this in particular, difficulty thinking clearly. We begin to ascribe, well, it's because a person is getting older, or they have dementia or Alzheimer's. But what we're looking at as we move forward is how this also could be a result symptomatic of traumatic experiences unrelated to those other biological or chronological factors. Difficulty with feelings. Again, we see anger, anxiety, frustration, a lot of addiction. Addiction is climbing, is increasing across populations, but also in the elderly. So disconnection or dissociation with one's body, unreal images. Again, these are symptoms that can be attributable to what elderly might experience due to, again, some of the, whether it's Alzheimer's, whether it's late stage Parkinson's, but it also could be attributable to trauma-related experiences. Okay. So I'm gonna go physical problems as well. And when we focus on behavior alone, it's like playing whack-a-mole. Right? At best, sometimes what we're going to get is reducing the symptoms, but again, addressing the underlying issues. So again, in the chat room, if you could put in, what % of communication do you believe is nonverbal? So before we've even said a word, how much have we communicated to a person, particularly someone in this context that we care about, we're supporting, we may worry about? What % of communication is nonverbal? Just put a number in the chat room. 50%, 60, 90, 80, 75, 75, 80. So far, the range we're seeing is somewhere between 50 or 40 and 90%. So the answer is actually 90% or greater. So before you utter a word, you've said it all. What are some of the ways we communicate non-verbally? Again, feel free to share in the chat room. There's eye contact, how close we are, posture, thank you, Sarah, body position, facial expression. What else? What addiction does just about, and I don't use that term lightly, does just about every adult and really child have? That's almost attached to them more than anything else? Phone. So think about that. That can draw away your eye contact. if you're talking to someone and that phone rings. So really think about, as we try to help in the context of whether it's trauma, toxic stress, or just being connected to people and showing them that we care, that 90% of communication is nonverbal. And then another large percent is how we say what we say. Okay. Yes, touch in particular is really a huge issue during this time because of the social, well, it's really physical distancing. As you look at this, here's the other part of this. Sometimes what we say is what we call the 4 elements of communication. What I say, what I meant to say, what you hear me say, and what you hear based on your perspective or perception and really experience. And I know we're not quite to the trauma yet. We're coming up next, how these all tie together. The elements of verbal communication. And this is after the 90%. Okay. So in your, again, the chat box, how many of you have heard of trauma or had a training around trauma and its impact on individuals? So 1 for yes, 2 for no, or 0 for no. Good. Excellent. So for those of you who haven't had a full course on trauma and adverse childhood experiences, it's potentially, and I really believe, one of the most powerful whether workshops, pieces of information that can affect physical, emotional, mental, and social behavioral health of seniors, children, of entire communities. And I would suggest absolutely taking those courses, but also make sure the one you take talks about what you can do with it. So trauma refers to the intense and overwhelming experiences that involve serious loss, threat or harm to a person's physical and or emotional well-being. This is Samsa's definition. We can see that it's an individual trauma results from an event, series of events, circumstances, things experienced by an individual that's life-changing. One of the things we have to do is we go back to that statement about the more we see, the more blind we become, is that we have this perception of, well, I got through this, so you should be okay. It is what is important, what was traumatic for that individual. I really want you to think about that. If we come with an answer, then we've already failed the test. This is fundamentally about asking the right question. Understanding trauma is not about starting with an answer, but making sure that we're asking the right questions, because it's about that individual and how that individual is a part of a society larger than themselves. You guys can read through these slides and I'll read through them, but if you can identify other ways in which people might be traumatized. So hurricane, fires, floods, human cause. I mean, you can read these. We also know about death of a loved one, car accidents, extreme and persistent poverty, bullying. And again, I want to be clear, Dave, thank you, but bullying not just for youth, but for people of any age. So family trauma, abuse, neglect, refugee and immigrant trauma. One of the things that with groups that I work with, and I did some work with Leading Age, as we talked about, well, these things, as we get into it, happen when they're younger, or they don't happen. People have lived a full life and they survive it. And as you'll see, the impact is lifelong. Again, I want to remind everybody that while we're here to talk about seniors, we're talking about the human system. So while you may be, as clinicians, as doctors, as supportive caring adults who may be taking care of loved ones, we cannot heal others without being aware of our own stressors or our own trauma. And some of that can be taken on, or it can occur by working with other people who are traumatized. And then vicarious trauma, the cumulative effect of doing this over years. I was working with some psychiatrists a week or so ago, and we were talking about assessing for suicide. And one of the psychiatrists was talking about how it's become practice. They're okay with it. And you have to be very careful that we don't develop an emotional callus. That's where we go back to say it's okay to be human. How do we continue to ground ourselves in a way that we can continue to feel? And then, as somebody said, as Paula put on here, what I call tertiary trauma, which is this indirect trauma that reinforces historical, structural, and societal traumas. It makes overcoming other types of trauma difficult, even in the presence of healthy supports. And these are the social injustice pieces, the not just systemic, but historical pieces, where we're constantly reminded that we're traumatized. So the work we do in Baltimore City is, as much as I believe in trauma, we do workshops on it and help organizations and communities really look at it. One of the things we have to be aware of is this another disease, another weight we're putting on someone? And that's where fundamentally trauma and resilience are connected. So knowing about trauma should empower us to build resilience. Otherwise, the tertiary trauma will get in the way of healing what we would call the primary and secondary and vicarious traumas. And so you have these, and that's where we get into these complex traumas. You have either multiple traumatic events at an early age or through a lifespan. And the impact can occur over the lifespan. The historical trauma. So if I continue, this is that bleed from vicarious to tertiary trauma. That this is not something that maybe I didn't experience directly, but as a culture, and these are great examples, whether it's the Japanese American survivors of internment camps, Holocaust, even 150 years later, slavery, 150 years post-Civil War. But these are ingrained into communities because we have not built resilience. It's not just about harm reduction, but health promotion. Okay. The racial trauma. Okay. And it is not just experiencing it, but witnessing it, and the sense of helplessness. So again, since so many of you seem to have had experiences with adverse or trauma, how many of you by extension have had a training or attended a workshop on adverse childhood experiences? Again, true or yes, 1, false, 0, if you've heard of that. So again, for those of you who maybe have had a course on trauma, but not on the adverse childhood experiences, they go hand in hand. And then the third leg of that stool is you have to have a course or part of a course that says, what do we do for individuals and systemically in this ecological approach to create power? So what we know, a lot of what we know about trauma today is found in this seminal study, the Adverse Childhood Experiences Study. And you guys can read this. The Center for Disease Control and Kaiser Permanente, led by Dr. Folletti and Anda, to understand the relationships of health, risk, behavior, and disease in adulthood. So this is important because what they looked at were traumatic experiences that happened to these adults prior to age 18 and how that impacted them, these adults, through their lifespan. And what's unique about this study is there were over 17,000 participants. and the distribution or the representation with of the people who were in the study more closely mirrored what the United States looked like than most other studies. This is fairly unusual for studies during this time. And you see 62% who are the age of 50, which AARP starts sending your membership at now. And so originally it was a 10-point study. So the higher you scored on this 10-point scale, so if you experienced 4 out of these 2 categories of ACEs, you have greater risk for all types of physical, emotional, and mental disease. So here's a breakdown of what they found about the population and exposure. But 66% of women who experience abuse, violence, and family strife in childhood found to have significant ACEs. 22% were sexually abused as children. Women were 50% more likely than men to have experienced 5 or more ACEs. And I'm going to say this through these slides so that I don't perpetuate the tertiary trauma. This allows us to know, to track for the symptoms, which often are the behaviors, and what we can do about it. This is not saying how broken people are, but how we can empower them. The way we empower them is knowing where those disruptive behaviors originate from. But it's not just women. 1 in 6 men have experienced emotional trauma. For those of you who work in psychiatric hospitals, 80% of the people in psychiatric hospitals have experienced physical sexual abuse. 66% of people in substance abuse treatment report childhood abuse and neglect. Appropriate statistic for Opioid Awareness Month. 90% of women with alcoholism. Two-thirds of all suicide attempts. 64% of adult suicide attempts. 80% of child and adolescent suicide attempts. And incarceration. So persons who had experienced 4 or more categories of childhood exposure out of 10, compared to those who had experienced none, had a 4 to 12-fold increased health risk for alcoholism, drug abuse, depression, suicide attempts. So as we go through these, take a minute, and again in the chat box. So these are the categories we look at. What is the physical impact of what we believe is aging, COVID-19, and with what little we've introduced of trauma on seniors? What do we see that we might have attributed to just getting old? So physically, emotionally, if you think someone's sad because of loss. What are some of the signs and symptoms that concern us about an aging population? Let's put it in that context. Increased pain, chronic pain. Good. Isolation. Increase in falls, depression. So, who's it? Thomas, reduce resilience to traumatizing environments. We want to be specific because what we do, one of the things we do, we put labels, we put names on it, and then we talk about shared language. What is more important than shared language is a shared definition. Because some may say resilience is somebody who has what was popular, I think about 10 years ago, was grit, that internal piece. Well, there is a bit of internal strength in all of us. We also know that social connectedness, yes, loneliness, are things that we know social connectedness is a real protective factor. Same thing, Sherry, loss of coping mechanisms. We need to identify what they are for an individual, But what does that mean for that individual versus population coping mechanisms? And lack of motivation, is that a symptom or is that the underlying issue? When we start ascribing behaviors as the issue, we've lost the opportunity to heal and to create health. Carrying chronic stress, yes. Here's what we know. The higher the ACE score, the greater likelihood of social, emotional, and cognitive impairment. Think of some of the things that you wrote in the chat room. Cognitive impairment. Is it because a person is aging and that's part of the natural aging process, or is it because they're carrying chronic stress? Health risk behaviors. One of the amusing, I guess, statistics you might say is that the incidence or the percent of seniors who are developing STDs or contracting STDs is increasing. Seniors are overrepresented, conversely, also in suicide. Yes, at least the loss of autonomy. But disease, disability, and social problems, literally the physical body changes related because the impact of trauma. So trauma and toxic stress. So the greater the number of ACEs a person has, we're talking about stroke, COPD, kidney disease, arthritis. So if we go back to what we talked about when we began to see these as functions of aging, there's greater risk because someone is getting older. You know, as caretakers, as medical institutions, we have to ask if that's symptomology, or if we believe the disease with the origin is trauma related, or is it truly physiological, separate from trauma? So could we be applying a cure for the wrong disease, or not applying prevention because we know that if someone who is younger has experienced a certain number of ACEs, that they're at greater likelihood for these bodily diseases. So what might we do differently? The emotional impact: depression, anxiety, moodiness, and anger. Would you say that you see that in many seniors who are struggling? I mean, the ones that we end up helping? So we are also talking about brain development, confusion, distorted thinking. Again, we might write it off as, well, the person's in their 80s or in their 90s. That's to be expected. It doesn't have to be. If we're asking, yes, bitter, confusion. That's the key, Melissa. If we see there's confusion and bitterness, maybe we need to ask the question, get a history about the trauma, and not just trauma when they're 18, but the lifetime. Social behavioral. And really, another way to think about behavior and disruptive behavior is to think about the sound on a stereo, which is to say, if I use my words and you didn't give me the support I needed, I'm going to turn it up by using my behavior. And the longer you ignore it, the louder I'm going to turn up that volume. But we have to ask the question, not assume what the problem is. This allows us, looking at some of these symptoms, behaviors, to say, hey, to not write off someone is just being old, that's what happened, but that there's something going on. That there were something and that we need to spend that time. Again, I'm going to go back and remind ourselves this is not just about the seniors, but this is also about us. And then in the longer session, we explore why all of us are doing what we do. And what we found many times that we are trying to heal ourselves by healing someone else. And then when that person continues to demonstrate disruptive behaviors, we feel rejected, become angry, and increases this cycle of disruption. Okay? And that person doesn't get the help they need. So we have to be careful, take trauma, its impact is ecological. It does not happen to an individual. It happens to individual connected to a larger community, whether that be family, neighborhood, city, county, state, and so on. Okay. In certain communities, there are higher risk, depending on where you live, higher concentration of poverty, homelessness. Contextual factors increase not only the risk for being traumatized, but the impact of that trauma. So again, to provide effective services, we need to understand that life situations that may be contributing to a person's current problems. If we are looking at behavior as the problem, we have failed. That is one of the most difficult things to do when you're helping others, is we look at behavior, we focus on that, and we perhaps have put a Band-Aid on a gushing wound or played the whack-a-mole. And in the last one, where we come to help, we can trigger because we are coming to solve this problem without understanding fundamentally what the issue is. And I also want to be clear that we're still talking about an individual, but we can do this at a population level. The Adverse Childhood Experiences, there's a group in Maryland and many states that we can look at, a person, a neighborhood, a community's what's called ACE score, fundamentally understand where the risks are so we can apply interventions, support that prevent the negative impacts. And that's what, and I'll say it again, like I said earlier, understanding trauma is not enough. Giving people the power of what to do with it is the most important thing. Because just by saying, knowing someone's traumatized, and then we could create another stigma and traumatize it that way. We have to empower people, not just engage them. So I'm going to give you this again in the chat box. What makes COVID-19 so stressful for a senior-centric human system? Again, my grammar there. But what are some things that COVID-19 exacerbates in terms of toxic stress and what could be how people are experiencing historical trauma? Isolation, increase isolation, yes. What else though? All right, vulnerabilities. What do we mean vulnerability? Vulnerable to what? Limits physical contact with people. Loss of control, excellent. Depression. Depression is symptomatic, but yes. Mixed messages from media, those are risks, yes. Decrease exercise. Yes, fear, limited time with family. Okay. So I think those things, the isolation and limited time are some of the big ones, but the one that sort of comes and goes in ways that people talk about, and this sort of aligns with food, but fiscal, financial challenges. If seniors are working part-time, if they have limited income, but their costs go up, access to food because they can't drive, they were dependent on others. Uncertainty. So grief, loss, and power. I'm going to pause that. Whoops. Make sure we're still sharing the right slide here. Yeah. So what we are talking about is grief, loss, and power. So I'm going to show you a couple slides. And I want you guys to, if this is going to work with me now. There we go. All right. Read this poem and the next one. So grief and loss. We think about when someone's passed away. 1,000 years, you said, I look at the hand you once held and the ache is hard to bear. And then we're going to go to, not cooperating. Should not dare to be so sad so many years again. A load is first impossible when we have put it down. The superhuman then withdraws, and we who never saw the giant at the other side begin to perish now. I don't know if we can do the breakout sessions. It does not look like it, but between those two, grief and loss, and this, particularly the last paragraph of this poem, or the last couple, of load is first impossible, about power. What is it that we can do to address the things that you identified before? Grief and loss are fundamentally about the loss of power. The loss of power of seeing people we love. Not being able to see the caregivers, access to food. Fear of death because we can't predict what's coming. So in the chat box, just type out what are ways we can empower people. With choices to do what? So you're right, we can't, if control and power is the issue, what can we do? So if we're providing it with them, we are giving them something. How do we empower them? Again, Dr. Hunter, from form and manage, attune relatedness to connect rather than fragment. So I want to push this. What does it mean to empower somebody? Check in on them, validate their feelings. So most of the suggestions, if not all of them, are what we can do. But how do we actually give them power? Let them be heard. We're getting there, yeah. So much of what we do is what we can do for others instead of how do we empower. Right? And we get stuck. It's that everyone wants change, but no one wants to change. Fundamentally, I'm asking you guys to think differently. And we're saying we want to provide resources to assist them. How do we give them the power so that they can create something? They can make the decisions. Brokenness impairs wholeness. Encourage independence. We got to get beyond the terms. And I hear you, Sherry, that she does. So, and someone said earlier that whether it's Zoom or videos are not enough, but what do we do on those videos? What are we doing with encourage independence? This is the hard part. Be specific, be concrete so that we are making sure that we are using the same language. Because resilience and the protective factors allows the ability to recover from illness, change, or misfortune buoyancy. The protective factors are conditions and attributes in individuals, families, and communities that can eliminate or lessen the impact of trauma. But that means we have to empower each other, not just assist. That language is so important. So give them names. Give them names of programs that they can use without assistance, right? How about fundamentally having them identify, be a part of that process of finding it? It's different when we have these long lists of resources, when we have brilliance in wherever we work. How about giving them the ability to say, this is something I need, and they'll say, well, let's do it together, instead of giving them something. Programs aren't enough unless they are part of developing it. To participate and to lead it. Because this is fundamentally in communities the difference between engaging and empowering. Engaging is often, all right, we've designed this program, we want you to be a part of it. Well, you've already designed the program. That may not be what that person wants or needs. So BCDA example hosted a drive-by celebration. If you're designing the program without the people who it benefits or supports, you may well have reinforced the trauma or the toxic stress. Because what you said is, I know what's best for you. Or because I see these behaviors, we're gonna do this. Yes, person-centered, but in this ecological approach, because what if you have a group of people who don't agree? You build a system for communication, you build community. This is how, and there was a reference earlier to, or some reading was looking at World War II. So the difference between soldiers who came back from World War II and Vietnam and what we're even seeing today in a lot of wars today. So people who came back from World War II were celebrated as heroes. They, had the parades, but ultimately they came back and were incorporated into the community. The greatest generation. They weren't just soldiers anymore. They were people within their community to look up to. In Vietnam, soldiers were vilified. In Iraq and Afghanistan, they were heroes. Once they come back, they were kind of forgotten about unless they were used for the military rank. They had no sense of self or community of person. So the question is how do you create community? How do you create a sense of worth? Not just because they're seniors, but because they are people. Fundamentally, that's what we're looking at, is how do we create community for people who have different context, but still want to be seen as equal as a person who's in their 30s. And the most important protective factors, social connectedness, concrete support in times of need, social and emotional power, not engagement. Yes, Dave, identifying shared and common interests. The program that was years ago where seniors were holding in AIDS, babies with AIDS. Right? Efforts where seniors are helping to tutor youth. There were seniors who were making masks. They were felt isolated, but then they felt much like the people who were home, the families who were home during World War II, were still contributing to this larger effort. Yes, use of music. We are creating positive social epidemics. Right? Yes, the singing in Europe, it was in Italy where they all came out and they sang out of their windows. Connect to who they see as similar and desire to align with, and create rites of passage, rituals for later in life. Okay, as again, we look at these, it affects, these are where we start, when we see changes in someone's physical sort of appearance, emotional pieces, social, behavioral, mental, and even their finances. That is when we start asking the questions about what's different. Not saying, well, it's because they're old, or I wonder if something happened. Use of animals to impart touch, yes. So we're looking at the individual and the environmental factors. So to connect the trauma to what we think is just a part of aging and stress. In the environments where you work, again, if your institution, place of work, how many screens for trauma through a trauma screener? Put 1. If they do not, put 0. Is anybody screening for adverse childhood experiences or other trauma? Not age-related trauma either. So did somebody unmuted? Did you have a question or a comment? So I have to say, I'm not used to doing presentations that aren't conversations, so forgive me. So it looks about, so Lisa, loss of history wouldn't necessarily be enough, because trauma is more than just necessarily a death. So spiritual perspectives affect trauma, great question. They can be building resilience if they support a person's health and welfare, right? That's what religion effectively is creating a cohort of people who believe and move through together. Where it can be negative is if it looks down upon that person's experience. It says, well, you should pray on it. It's, that's not okay. And we know this if we think about people who have thoughts of suicide, and someone may say, well, if you take your life, or if you lose your life by suicide, then you're going to hell, right? As opposed to having something to believe in. Fundamentally, even though we're using ones and zeros, which are digital, which are binary, people aren't 1 or zeros. They're not binary. They can't be fixed like a car or a table. This is why conversation and asking questions, just like religion, positive and negative, anything is specific to that person. And then we look for how their groups within those communities that share similar either experiences or strengths. So as we look at building strength, you have to look at this as an ecological piece. What are the things, and this is what we talked about, that promote health and wellness for the individual? If you want to help this individual, you might have to talk to their spouse or their best friend. And if they don't have those, it may not just be getting them engaged in an activity, but connecting them with someone who they feel comfortable enough to engage in activity. You're building an alliance. Okay. And then this is part of when we look at individual factors in this cognitive behavioral approach, the reinforcing of pro-social thoughts, feelings, and actions to strengthen self-efficacy. So what we're talking about is a lot of people talked about isolation. But again, what do people, as we get older and more isolated, feel about their value to others? What do you think? When you're isolated and you don't hear from people, What might someone think about their value to others? You can put that in the chat box. Or if they can no longer work, even if it's volunteering. Remember the three themes that really encompass a lot of this. They aren't important. So they aren't important. So they're grieving their value to others, a loss of power to shape the world. Disconnected, that's social connectedness. So it's grief about not being connected to others, that loss of power, your standing in your community. This is fundamentally why creating programs without not just the input, but the direction with seniors as part of the design, at best have fleeting impact. You must give people purpose and allow them to select what's important, because the decision-making alone is empowering. And that's, so you go back to that earlier slide, you said the power of community, belonging, the power to shape it and to be a part of it. So I stole this picture, but think about this. The therapeutic relationship or community relationship, our brain, we are an amalgam of our experiences. When we talk about the means by which a therapist and client hope to engage with each other, as we all become sort of clinical supports to those in the community, regardless of age, but certainly those who are seniors, we are literally helping their brain stay strong, develop, or wither. And to give you an example, so my mother will be 89 next month, lives 5 doors up from me. My father passed away 13 or 14 years ago. And my mother cuts her own grass and shovels her own snow. And repeatedly, when I see her doing it, I said, Mom, you can't do this. You can't do it for 2 reasons. 1, you're going to be 89 soon. And 2, you make me look like a deadbeat in the neighborhood. Right? But the reality is, and I know that if I literally started cutting the grass, getting up or even earlier than she does to shovel the snow, she loses a lot of what you all reference, the sense of power and purpose. And my mother and my father were college professors at Morgan State University. And so all of this, and now, you know, before my father passed, he had cancer and a glaucoma and Parkinson's, so she took care of him, gave him purpose. They'd been married for almost 50 years. So her purpose came to be her garden, cutting the grass. And Edwina, correct. I'm giving those examples. Certain people love to sit back and read. Others to play cards. It is very much empowering the brain means that we have to empower each other. And that may well be empowering someone to say, you know what, they like being alone. But many times they still want someone to check on them and say, are you okay? Okay, you're fine, I'll go on my way. We are an amalgam of our experiences, of our community. Okay. And I bring this in late, I usually do it earlier, and is about our relationship, bringing this back around, this ecological approach. Communication. We communicate most effectively when we listen. Put the answer in the box or unmute if you like, but what are we communicating about that person that we're listening to? What are we communicating to them and about them when we listen? So that's about us, not we care. There we go. Annie, you got it. The fact is that what they have to say is important, and by extension, they are important. I still struggle with this when I call my mom. I call her every day. And she tells me these stories about what's on the news. Well, I watch the same news stories. And it's frustrating because I have this window of opportunity that I dedicate to her and I want to have this conversation, but I have to remind myself her world for most of the day, that's what she sees. And she wants to have a conversation. So I hope I'm good at it, but I bite my tongue and listen and not say, oh yeah, I saw that story, or I heard that too. Just by listening, I'm telling her that she matters and that I love her. And that think about how many of the behavioral problems that volume has turned up to 7, 8, or 9 on the community stereo, because when someone needed you at 0, 1, or 2, we didn't hear because we were talking. We're developing programs for them. Yeah, Thomas, there's like the quote from Ubuntu, which is the African proverb, I am because we are. But people misinterpret it, believing that it means, like we often say, in order to take care of someone else, we have to take care of ourselves. No, because then we're enmeshed. What we really want to look at is sort of these concentric circles, or even the Venn circles, where you are important because you are important. Not because you're a mother, a father, a doctor, a lawyer. Parents are people too. Seniors are people too. They're not just seniors. They're people who have a few more decades than many of us. Don't define them by their title. So they're important as individuals, and because they are valued and important, they contribute to that us. And then that's where we'll get into self-care. How many of you have heard of the starfish story? You put 1 for yes, 0 for no. Good, there's enough of you on here that I will still put it up, but fundamentally it talks about what power can look like. So just take a minute to read this. Right. It's the things that we say to our parents. Mom, you need to stop shoveling the snow, or cutting the grass. I don't understand why you're putting decorations up every year. You don't have kids anymore, or this. Because it matters. It matters to them. And if we don't see all 7 billion people as 7 billion individuals, then we failed, and that's hard. That's an ecological approach. We have to come back and say, you know what? 9 out of 10 times, this is what happened. But how many of you would like to have your mother, father, grandfather, child, or someone you care about be that 10th person that got treated like the other 9 because they fit a pattern? Fundamentally, that trauma we talk about goes back about us asking questions about what happened, so that we can either learn from you what strengths you built, or how we help you build both internal strength but social connectedness that empowers you going forward. So when you get overwhelmed and start doing that 9 out of 10, ask yourself, do you want to be the starfish that gets left on the sand? Do you want to be that one, or do you want to be valued like everyone else? Not in the same way, but seen as valuable. Again, I go back to things that are funny and empowering. Life is meant to be lived. You have to play, work, inspire people to really enjoy life, find purpose in it. Any of you give an example of where you've seen seniors, not what we got seniors to do, I understand that, but where you've seen seniors during COVID-19 rise to the occasion to do things? I mentioned one earlier where they made masks, took to sewing masks. You can type it if you have any examples, but I will also tell you, if we don't aren't able to identify this, it may not be that the seniors aren't doing it, but that we aren't building resilience by reinforcing their thinking and feelings of self-worth and power. Oh, sorry, the question is, can anybody identify ways in which they've seen seniors sort of rise to the occasion during COVID-19, where they've taken on a role or sort of challenged that norm or what we believe, the isolation, the sadness? Sending postcards to Pennsylvania ahead of the election, yes. Learning technology. Volunteering. So what everybody's doing right now is actually building resilience and reducing the impact of trauma, because you are reinforcing their protective factors. It is not always what we do, but how we promote someone else's power. So if you want to continue health, you have to promote health. Seniors are now providing childcare and help, yes, oral history class. Because what we believe, the news, the atypical is the typical, because that's what gets reinforced. You want to build health, you promote health. That we see signs and symptoms as signs and symptoms of something else. People aren't cancer, so we shouldn't say that people are old. People are people, they're older. People aren't seniors, right? They are seniors because they're older, but that's not who they are. Really emasculate for men, or it can really take the power away. Oh, you're a senior citizen. The connotation comes with that. And the very strength that they need is taken away because of what we associate with people who are older. Sending senior meals. Good. Sharing their wisdom with their children and grandchildren. Yes. So one of the most powerful things you can say to anybody is you are not alone. Because if you go back to your chat, the ongoing theme is about loneliness, loss of power. It doesn't necessarily mean that you have to be physically there. Again, I go back to World War II, where, Needless was it Wednesdays, the savings bonds, the things that we're actually missing in COVID-19 right now, positive social epidemics, that we're all in this together. We don't like it. Some levels you may not agree with it, or we may not agree with it, but because we're in this together, we're doing this together. If you work in a nursing home or congregate care, is how do you build a community where neighbors still knock on the other neighbor's door and check in on each other, which could actually reduce some of the work for staff. That you build community, not communities. And it starts with something as simple as that you're not alone. So I want to make sure that we are in the context of this ecological approach is coming down, so you can take any questions or anything, is that we're talking about, again, this is not just about seniors, that we have to recognize our own burnout, that if we don't understand that there's no one who hasn't experienced a loss, but my loss is separate than your loss. That we come in every day wanting to do the best, but we bring in our own stuff from home, or come home with work still in our mind. We are part of the community, that we're not there to just serve it, but to build it. And so that means that emotional exhaustion, the depersonalization, reduced sense of personal accomplishment develops as a result of general occupational stress. It's not, this is more toxic stress, but building that toxic stress can contribute to the impact of trauma in others. It can be traumatizing. And what we see in both the caregivers and in people who work with seniors, depending on what your role is, increased anxiety, reduced energy and focus. And those symptoms look a lot like the ones that are sometimes attributable to people who are getting older or other issues. So there's still people, and these signs and symptoms are signs and symptoms related to stress, trauma, and the fact that there isn't a supportive community that exists with purpose to move forward. So I'm going to stop there. This is, like I said, kind of challenging to do, and just to talk, it's not my norm, because what we do is build conversations and capacity. But if you have any questions, I'd be happy to take them.
Great. I did get 2 questions.
Or comments.
Yep. No, and people, you're welcome to take yourself off mute and show your image if you'd like. I did receive 2 questions that I'll ask, and then if other people have other questions, feel free to ask, or you can send the message to the chat box. The first question arrived very early on, and it may have been answered as you went along, but just to go back to it, someone wanted to know whether trauma can be chronic.
Trauma can be chronic if you think about, and we talked a little bit about it, sorry, somebody needs to, in ways, persistent poverty. But I want to be sure that I identify that fiscal bankruptcy does not equal moral bankruptcy. So, and to give an example is, so I'm biracial, my mom was African-American and she grew up in the Deep South. She was one of 12, okay? And so you're talking about in the 30s and 40s and 50s, it really, through a lifetime, you experience persistent racism. And she grew up in a 3-bedroom, 1-bathroom house with 11 or 12. And she would want to get her PhD and become, a doctor of chemistry at Morgan. So what we've done in terms of chronic trauma in that case is said that if you are poor, you're also not valuable. So homelessness, poverty as a crime, those things that are chronic, staying in abusive relationships over long periods of time, that's also a really good example of where emotional safety is more important than physical safety. That's experience of trauma, yes.
Okay. And then the second question's a little bit more complicated perhaps, but early you said that the focus can't be on yourself. You had asked in the chat box, why do we care for another person, or why should we interact with another person? And many of those responses came back, because the person's valuable, they matter. And you, let me see if I get this question correct. You made the comment that the statement, need to take care of ourselves in order to care for another person, we need to kind of twist that around and put the emphasis back on the person. But then this person wants to connect it back to burnout. If they're experiencing caregiver stress and burnout, isn't that focus back on them? And how do they turn that around to be more positive for the person that they're providing care to?
So one of the hardest things to do is realize is that you're both an individual and part of something greater than yourself. That's the Ubuntu, right? The Ubuntu is you are important as an individual, but we can also become addicted to helping other people and lose our sense of self. So what you have to do is 90% of communication is nonverbal. We have to have self-care so that we're healthy, but also people are watching. When we go to help them, we have to be clear sometimes, hey, I'm having a difficult day, but because you're important, I'm here. And there are going to be days where you have to both see yourself as important enough and that person is important enough to say, you're not the right person today. It is really hard if we believe that we have this power to change someone else's life, which is part of that problem, that we can be the only one that saves them instead of empowering them to be healthy. So that's the difference, is creating health and empowering both people and seeing that relationship and knowing when I'm not the right person, which means I have to trust that I have another coworker, somebody else there. I'm not sure if that answers the question. It is a hard concept, but
Yeah.
otherwise we would absolutely be addicted to helping.
Yeah, well, and if you even think about it, someone, for example, who's caught in the sandwich generation, so they're providing care for perhaps a parent who is onset of dementia and still has teenage children, or maybe they're financially helping their children, and how do they balance that and be there for both and ask for help or accept help? Because I think people oftentimes will offer help, but it's the acceptance of help. Like, I can do it all, and then you don't do anything very well. So what is that balance?
That's a great example of lifespan. So if you have a child who you're taking care of and a senior you're taking care of, but you refuse yourself, and not maybe purposeful or conscious refusal, but you don't help because you have two people who are dependent and you don't want to be dependent.
Right.
And that's really hard, is that we're connected, not dependent.
Right, good. All right, got another question came in. Dave would like to know whether a whole society or a country can become traumatized.
Yeah, and so this is going to sound somewhat political, but I do believe it, not because of the current thing, but I believe that, and somebody asked in the chat about institutional racism, the shift as the larger population of percentage of the United States becomes less white is about loss of power and control and norms. This is what we see. So I don't see this, so it can't happen. I don't see racism, so it can't happen. So we begin to do these things that perpetuate the very thing that we don't say exists. But when we have these conversations, it becomes threatening. Because what if I tell you the way you perceive the world is not the way I perceive it? It then becomes an argument instead of a conversation. And you can't, the most powerful thing you do is not fight against, but fight for something. And you'll tend to have fewer wars.
All right, that's all the questions that are in the chat box, and you answered the one that was out there for everyone, institutional trauma. And I see people are popping on with their images, so thank you. I see Nancy. Does anyone have a question that they didn't ask in the chat box that you would like to? The floor is open. We have a couple of minutes if anyone has a question for Dave.
Like I said, I also like to thank you all. Sorry, I apologize for the technology issues. It's also, and Paul, I can tell you the trainings we do are much more, and consulting are much more engaging. This is a lecture. Life is about engaging and learning and not telling. And so this is sort of more challenging for me. So I hope some of the information was useful, and particularly since it was so condensed.
Yeah, no, I completely understand. As a presenter myself, I understand. We do want to hear from Vicki Mazer, Dr. Vicki Mazer, who is the Dean of the Graduate School at McDaniel College, and she's going to close this out. Except Nancy, I think, do you have a question? I saw you pop on there real quick. All right, Vicki.
Well, it has been a wonderful conference, and as Diane mentioned, my name is Vicki Mazer. I'm the Dean of Graduate and Professional Studies at McDaniel College, and I'd just like to take this opportunity to say thank you to everybody for spending the time with us this morning. I know COVID has presented a number of challenges for all of us, but I try to find the silver lining in everything, and I think that the silver lining for us today is that we've been able to attract people from much further away than we've been able to attract when we have done our on-site, or at least more of you who might be further away from McDaniel. And while we would have loved to have hosted this on-site, it has given us an opportunity to extend our reach. That's not to mention the silver lining that some of us may have on a daily basis in terms of not having to necessarily always do our makeup before we get on a conference or dress up before we come in. So there's always a silver lining, even if there is a challenge at some point. I would also like to take a moment just to say thank you to our supporters, Home Instead, Johns Hopkins Geriatrics and Workforce Program, Maryland Living Well Center for Excellence, and Mutual of Omaha, James McCarran. Without their support, we obviously would not be able to host such a wonderful event. I'd also like to take a minute to say thank you to our speakers, Secretary Kramer, Dr. Chen, and Mr. Brown. They have certainly given us things to consider, think more deeply about, and even some things to act upon when we leave here today. And I would encourage you to do that. Last but not least, I would like to say thank you to some folks that are behind the scenes on a conference like this. And while it looked very simple today, with very few technology glitches, it took a lot of work and a lot of hours to put something like this together. So Meredith Hockman, Andrea Sullivan, Daniel DeCou, Min Park, Susan Hall, Angela Janis, and of course, Paula Blackwell and Diane Martin, and all of the others that may have had some involvement in helping us pull things together. I would also like to just to say, I want to remind you to do the pre-survey. That link was posted in the chat. But the most important thing also to remember is that you will be sent a post survey by email, and we would ask that you fill that out. That will be linked to our door prize, and we will be giving out a door prize both to a student and to an open attendee. And then I think last but not least, I would just ask you to stay connected with all of us and look for future conferences and events that might be coming. I'd also like to say thank you to the University of Maryland GEARS program and our Central AHEC partners with us here at McDaniel to put this conference on today. I think that we have all learned a great deal, and I think that it has also sparked a new partnership and relationship that you will see grow in the future to help serve you all as professionals in the field and serve our communities. So thank you all very much. We do appreciate you coming. And I will turn it over to Diane or Paula to say anything that I may have missed.
I think, Paula, do you have anything?
Thank you very much. I don't have anything to say other than in closing, thank you very much for spending this time with us, and that I hope that you found this experience to be enriching as well as rewarding, and that you'll be able to share the information and use the information in a most meaningful way.
Have a great day, everyone.
Bye, thank you.
Thank you.
Thank you very much.
Thank you.
The AHEC Scholars Program was an unprecedented opportunity for me as a medical student to work with an interdisciplinary team of students. I feel like it allowed me to understand what different professions can offer for my patient and allowed us to provide really comprehensive care. I think that because of the AHEC Scholars Program, I feel more comfortable tapping into our interprofessional allies in a clinical setting so that we can meet the biopsychosocial needs of our patients going forward. One of the things that impressed me most about the AHEC Scholars Program was that they listened to me when I had feedback to give about how to improve the program, and that was really important to me because I felt like I was being heard. One of the things I learned from working with the other disciplines was how much I actually knew. I'm a PA student, so it kind of made me realize that I know a lot more than I actually think I do working with the medical students, and I actually learned a lot from working with them as well. One of the unique things about the AHEC Scholars Program was that there was a clinical and a didactic component. So one of the things I really loved about it was that we had the opportunity to have lunchtime conversations with our peers, and then an integrated telehealth component with the ECHO program. So that allowed us to speak not only with people from different disciplines, but people from different parts of the state to go over comprehensive case conferences. Although this was an additional component compared to my other clerkship experiences, it really felt like it was helped to balance the program rather than having it take up more time during the day. It just sort of provided flow and continuity throughout the program.
The program allowed me to spend a lot of time with my patients. I really got to do in-depth interviews with them and got to get to know their history. I never felt rushed or like I couldn't actually take